Just wanted to welcome everybody on behalf of Michelle and I. We're very excited with this, our first pop-up symposium for Vaccinate LA, which is a program that rose out of the needs of the very many communities, especially the African American community and the Hispanic Latino community that have been the hardest hit with this pandemic. And so this has been really an incredible labor of love. We have so many people that have participated so far in these efforts, anywhere from our listening sessions to our town hall meetings. The program has multiple components that Michelle will get into more details later and also as we go throughout the day. But we have just a stellar group of people that are working with us, and we're very, very excited. And we thank each and every one of you who will be contributing today with your expertise, as well as your thoughts and your thinking about some of these issues. Michelle?
Yes, great, thank you. And this is an initiative that's funded by the Keck Foundation as part of the COVID Rapid Research Fund. Really there's many components actually to this. But one of the things we wanted to do was to really tap into the assets that exist in Los Angeles and specifically at USC as we think about how to protect those in our community that are most vulnerable, how we think about understanding where there are sources of vaccine hesitancy, and also how we think about strategies to increase vaccination in these communities. And we're really thinking about many different approaches. It's a multifactorial approach with education. We have faculty who are developing photonovellas. We have faculty who are developing PSAs. We have faculty who are developing short videos that will be targeted to specific populations. We have a partner, Wondrous, who's with us today, and they will be with us and helping to facilitate some breakout rooms this afternoon and can describe a little bit more about themselves, but they're there as partners, as creative design partners. And so really, how do we think about messages that can be very specifically targeted to address sources of discomfort, to increase comfort with the vaccine, and to really motivate and engage different communities so that they are more comfortable with the idea of being vaccinated. And at this point, obviously, many people have gone and been vaccinated. So those who were just eagerly waiting for those vaccinations to become available, they've gone, for the most part, they've been vaccinated. So now we're looking at a group of individuals that for a variety of different reasons are waiting and holding back a little bit. And so these are the populations that we really want to target educational messages to. And not just educational messages, thinking about very concretely, what are the barriers and the logistical challenges to becoming vaccinated, and how do we support and our communities to overcome some of those barriers. And we'll be talking more about some of those strategies, and we want to brainstorm with you this afternoon about what some strategies are. But one example are community vaccination navigators who will be there to help people again navigate sometimes complicated systems. So there's lots of moving parts within a very short time frame. We have really 6 months that we're really trying to organize and mobilize and do many of the activities. That's our grant cycle, but I think more important, there's just such urgency right now that everyone become vaccinated. So we feel like we're racing against the clock right now to encourage and support communities. One of the things that we also wanted to do, though, as a starting point was really to bring together USC faculty and investigators who are doing research in this area and learn from one another. We do have 3 different campuses. Sometimes we don't, and certainly virtually, we're not bumping into each other. We don't necessarily know the work that one another are doing, nor do we know what the findings of our research is. So this symposium is really an opportunity to bring folks together, to share what they're learning, and then for us all to think as a group, what are the implications of some of this? We are recording this session. We do plan to create a summary report. This will be shared with all of you. It will be shared with other members of the USC community. But I think there's going to be components of it that we'll want to share with some key stakeholders, which could include the LA County Department of Public Health, the State Department of Public Health, both of which are very eager to learn from ours and others' work. And then obviously anyone who is in this space of trying to support and encourage vaccinations in our county. So with that, let's go ahead and transition to the next slide. We are going to kick this off with some really terrifically talented individuals in presenting their work. First, we're going to hear from Catherine Choi, who is the Vice President and of Strategy and Evaluation at Ad Council. She's going to provide hot off the press data that will help to provide a national perspective in terms of what we know about vaccine hesitancy and uptake. Next, we're going to hear from Dr. Kayla De La Haye, who is an associate professor in the Department of Preventive Medicine at Keck School of Medicine and at USC. Really from the onset, Dr. De La Haye has been just right there in the middle of trying to understand the impact of this pandemic in Los Angeles, and has been crafting questions included in Dorsey's Understanding the Coronavirus in America survey, which is really, it helps to provide a local perspective with respect to vaccine uptake and hesitancy. Then we'll hear from Dr. Sonali Saluja, who's an assistant professor in clinical medicine, and I hope I'm not disclosing something that I shouldn't hear, will be the new director of the USC Guerra Family Center for Health System Science and Innovation. Dr. Saluja is an amazing scientist and has been conducting surveys in Los Angeles County also that help to provide a local perspective related to vaccine uptake and hesitancy. And then finally, we're going to hear from this, like, I feel like drum roll, like, you know, fireworks, Dr. Richard Dang, who I honestly believe is one of the most precious assets in LA County right now. Dr. Dang is an assistant professor of clinical pharmacy at the School of Pharmacy at USC. He also chairs the California Pharmacists Association COVID-19 Task Force. Dr. Dang has just been extraordinary in his work to mobilize and organize resources, which has led to thousands of residents in our most vulnerable communities being vaccinated. So with that, I will turn it over to Catherine.
Great, well, thank you so much. Please just give me a second while I try to pull up the presentation. All right, can you just give me a thumbs up if you can see it? Perfect.
Give my thumbs up.
Thank you. I'm going to try and make this bigger. So really appreciate everyone for having me here. We at the Ad Council have been doing pretty extensive research into vaccine confidence since last December. And so we also have extensive research into different audiences. And so I'll recap some of the key things that we've learned, as well as some messaging considerations as you all go into your breakout group. There is a lot. I only have 10 minutes, so I'm going to be talking fairly quickly, but I do want to point out that on our website, adcouncil.org, we have an extensive amount of our messaging insights for different audiences. We have a lot of different creative that's also shareable, and we do encourage many partners to share and to use the assets that we do have available. So first, to kind of level set, as you all know, vaccine confidence and the vaccination rates have really increased over the last several months. But we at the Ad Council are really focusing in on this wait and see population. These are folks who are not yet ready to get vaccinated in the next month. They're wanting to wait a bit, many around 3 to 6 months or even a bit longer. And while this has significantly decreased from about 50% in December to 24%, we still know that this is a really key group who's still movable and help us to achieve that herd immunity level. And then, of course, with those who are resistant, at least with the Ad Council, we're deprioritizing this group, knowing that sometimes a mass communication approach may not reach them as well. But as you can see here, while there was a decrease in this percentage, there was a slight directional increase, at least in April, especially due to the J&J response. To break down this movable middle, or to break down vaccine confidence among different audiences, you know, we've always prioritized Black and Hispanic audiences from the beginning, and especially over the last few months have been seeing how much conservatives in particular make up this wait and see as well as vaccine hesitant population. So really looking at creating assets that are specifically speaking to their values. But again, as you can see, the trend overall in this movable middle population has significantly decreased across the board, but there still remains a lot of opportunity to reach these audiences. Now, vaccine hesitancy, when we look at this across different age groups, once you get above the 50+ group, you can see that their vaccination rates are much, much higher. But when it comes to this younger 18 to 49-year-old group, there's still a lot of opportunity here, especially there's a slight higher level of the wait and see of the 18 to 24-year-olds than these other groups, but not by that much. And so for us at the Ad Council, we're really starting to hone in at this 18 to 50-year-old age range. I'm sure many of you are very aware of the barriers to vaccine confidence, but here are some of the key factors. And one is the speed of the development process, especially not knowing very much around the mRNA technology. People are very concerned about it. They feel that the rush in the development process meant cut corners. And so many of them are really wanting to, again, have that wait and see. They want to wait for more data to come out to demonstrate what the side effects are, and especially what those long-term safety side effects are. There's also a significant amount of distrust in the government, in mainstream media, as well as in the different pharma companies about them being transparent about the vaccine risks. And of course, we see that this distrust is much higher for Black and conservative audiences. And when we look at risk assessment, really a lot of this movable middle still very much are just concerned about the unknowns of the vaccines. And because of that, they see that as a greater risk than the virus itself. Now, in terms of perceptions of safety and efficacy among the Black and conservative Americans, you can see that really it's much higher concerns much higher belief in safety and efficacy around for Hispanic audiences and Asian audiences, but much lower for Black and conservative groups. And of course, many of those who are wait and seeing really just safety is that foundational consideration. Their questions are very much around, again, those long-term side effects, especially if the vaccines cause infertility or does it affect pregnancies. We especially see that as a major concern among the young adult audience. Many also wonder about how the vaccines will affect them if they have pre-existing conditions. We also see a lot of questions about the efficacy of the vaccines, whether or not it will help prevent them from getting COVID and not just preventing hospitalizations and deaths, but they want to know about the transmission. Of course, with the latest updated mask guidelines, this really helps to demonstrate that the vaccines help substantially reduce transmission. But just to note that the data that we have here is based off of April data, so pre-updated mask guidelines, but right now we do have message testing going in to understand how the guidance has affected vaccine motivation. We also see many people asking about the protection against variants, and especially with a lot of vaccine information out there, when we talk about variants, that actually piques a lot of people's interest. They want to know this question, and they want to know, so that is one of opportunity for us to continue exploring of how can we message more about the variants in a way to increase confidence. And of course, there are still questions about the development process and also access. Just to explain, this chart, of course, doesn't mean that it's a funnel, but really represents more of the type of questions asked by folks. But access doesn't mean that it's less important than other safety questions. It's really just more in volume. And of course, it is still important, especially as we see among the Hispanic and other immigrant groups. There's a lot of questions about whether or not getting vaccinated costs anything. There's a lot of questions about where specifically to go to get vaccinated. We've also been hearing a lot about whether they need health insurance or if they need to prove citizenship to get vaccinated. We have here the open but uncertain segment profile. I'm not going to go into the detail of all this, just knowing in the interest of time, but we can share these slides out so you can look a little bit more into these. Now, the key things that we've really seen resonate across all different audiences is really the importance of being empathetic. That many people have a lot of questions and concerns, and that they are very valid, and that we need to acknowledge them rather than challenge them. And as a response, we need to also provide the facts, provide them with the statistics and the data that actually many people really want. They want that data. And so being transparent about what we know and what we don't know can really help alleviate a lot of those concerns, as well as help people understand what those benefits are of vaccination over the risks of COVID. Of course, leaning into the idea of protecting oneself, their loved ones, and those most vulnerable. For younger audiences, while for many this is still an important thing, when we connect things back to moments missed, such as traveling, especially, that ranked very high with many groups, as well as getting back to large events like concerts or sporting events. Those are also very motivating pieces of more of the emotional side that motivates people. And of course, having a positive tone. And avoiding negativity and fear, really, especially the conservative audience, really is quite resistant to any sort of emotional appeal. So for that group, we really try and lean in more into fact-based messaging, and avoiding any kind of messages that talk about the right thing to do, which can come off as pushy or accusatory. And then we also want to just avoid overpromising what the vaccines can do, and we try to stay away from the language of back to normal, because for many, normal will never be getting back to what it kind of was like before pre-pandemic. So I think I've mentioned a lot of these other pieces here, but as you all know, how much trusted messengers are particularly important. It's not always the content and the message, but really who's delivering that content and message. And so for us, what we've been doing a lot of is linking some of those trusted influencers and messengers alongside medical professionals and experts to create the dialogue around vaccine information and to deliver specific information and answers to questions that people have. Now, I'm going to switch my screen and just share a little bit more about some of the key things that we've been seeing working well with the young adult audience, but also, I believe, working well with others. And that's social norms for the young adult audience. And many have consciously said that seeing other people getting vaccinated, helps them understand that, okay, they are okay. They haven't had any major side effects. That encourages them to then also get vaccinated. I mentioned the facts and stats, but the other interesting thing to think about is we showed in some of our research more illustrative videos about the vaccines and comparing that to COVID-19. And we found that actually helped people better internalize the benefits rather than just saying it or showing text. So thinking about how we can provide these visualizations can be really helpful. And of course, balancing the emotional and rational needs. If we lean too heavily into the emotional side, people will feel like that it might be propaganda. But when we connect that data and address their questions and then show how vaccines are a way to get back these moments missed, that becomes a much more powerful message. Okay, I'm sorry I spoke pretty quickly, but if there are any questions, please feel free to reach out. And I wanted to also just let you all know that on June 2nd, we will be having a Ad Council and COVID collaborative briefing on getting more into the young adults insights, as well as our recent research of parents of children 12 to 15. So if you would like to join, feel free to reach out, or I can send the invite information to Claire if you don't mind sending it out to the rest of the folks.
Great, that was fantastic. Thank you so much. And as we transition to Dr. De La Haye, I'm sure there are lots of questions. And so one thought is you actually could start asking your questions in the chat box, and we could ask Catherine to be responding during the next presentation. And if you have questions for Dr. De La Haye, same thing, maybe add those to the chat, and she can respond to those afterwards, and this will be a sort of running dialogue in parallel. One of the advantages to having this virtually. So thank you.
Okay, can you see my slides okay?
Yep.
Great. So that was a really nice setup. Thanks, Catherine. I'm going to touch on a lot of interestingly similar trends, and then also some differences in LA County. And so this is really a snapshot of what's been going on in LA County that we've been gathering as part of Vaccinate LA, and as well as part of a project called Stay Connected LA, which was sort of the beginning project of all of these things, also funded through the Keck Foundation. And these are both trying to develop material for the community around COVID. And we've been using the data that we're gathering to help us get a pulse on what is going on for the LA County population, but also to understand where there are disparities and what differences are going on across different subgroups in the county and groups that are experiencing more disparities in their impact from COVID. And the way that we've been using this data is really as a snapshot and triangulating it with other information that we get. So it's data that we've been both sharing back to community members and community partners to communicate to them what we know about what's going on with COVID-19 in the community, and to get their reactions to it. A lot of these statistics I've learned so much about the community comments on these statistics and what they feel like they mean for them. And then this data has really been triangulated with a lot of rich qualitative data that you'll, I think, hear about today as well, that's being conducted as part of these projects. In case anyone hasn't checked the dashboard in the last couple of weeks, this is where we're at right now in LA County. We've had recorded 1.2 million cases and over 24,000 deaths. And throughout the pandemic, we have seen disparities across race and ethnic groups in COVID cases and deaths, in particular the Latino community that you see on the top left, that make up 49% of the LA County population, but 65% of COVID cases and 54% of deaths. And on the bottom right, you can see how that plays out in different communities across LA County that are made up predominantly Latino communities versus other communities in the county, and how some of the big spikes that hit LA County really disproportionately affected Latino and African American communities. We've been drawing a lot upon county data, but also data from the USC Dornsife Understanding Coronavirus in America tracking survey. There's a lot of information online and a lot of interactive data that you can access, both at a national level, but also an oversampled and large representative sample of LA County. So this has been sampled to be demographically representative across the county. There's about 1,800 adults that have been surveyed typically bi-weekly since the pandemic hit in March 2020. And about 40% of that sample is made up of Latinos and 13% African Americans. And so we've been drawing on this data a lot. One of the things we've been using the data from I'll call it the UAS, it's Understanding America survey. So I'm going to use that as a short. One of the things we've been really trying to monitor in the UAS data and adding questions to this panel survey through some of the Keck funded work that we've had is really the breadth of disparities and the impact this has had. And we really focused in on the Latino population when we started doing this work for Stay Connected LA. And so you can just see on this graph here how many different things we see greater impacts on in the Latino community than non-Hispanic whites, from poverty and unemployment to how many people could work from home safely, how many people were missing rent or not paying in full. And I've been doing a lot of work on food insecurity, and we've just seen really huge disproportionate impacts on Latino and African American communities in terms of food insecurity. What we've been really focused on in the last couple months has been on tracking vaccinations. So in this slide is current LA County Department of Public Health data about how many folks have been vaccinated. This is what's on their website as of May 5th was their last update. That had 59% of residents in LA County that were 16 and up that had at least one dose of the vaccine, and 44% fully vaccinated. And you can see how that number drops off as we look at 40% of Latinos and 37% of African Americans. And you see sort of the same pattern of disparities happen when we look at seniors. And again, that plays out very differently across neighborhoods in LA County. So vaccination rates as of May 9th were 71% in Santa Monica relative to 53% in East LA or 39% in Watts. So the last few slides I'll share is kind of digging into using this UAS data and digging into why we're seeing these differences and what signals we can detect in LA County about differences in beliefs and intentions about getting vaccinated. This is the UAS tracker since March of 2020 about people who said that they were very or somewhat likely to get vaccinated once it's available. And then they started combining this in December with people who had got vaccinated. So what this is really showing you is folks that are either vaccinated or say that they're likely to get that done. And you can see how it's increased as people get vaccinated and as intentions increase. But you also see the disparity between the blue line, the white population, and the Hispanic and Black population has actually merged together in the last couple of months. And I'll talk a little bit more about that on the next slides. So this is looking at unvaccinated folks. And when the panel survey is asking them, how likely are you to get vaccinated once it's available? So when we look at December, no one had really gotten a vaccine yet. So there's a lot of enthusiasm and groups, a lot of people who are looking forward to getting vaccinated. But we still have this group at the bottom of unlikely or very unlikely hesitant folks that sort of was getting better and better between December and February, and that group was declining, perhaps as more information is coming out. But what we've seen happen in the last couple of months, as more people get vaccinated and as this group of folks who are more hesitant and waiting, when we look at their profiles now, we actually have a third of these folks in the Latino population who are saying that they're quite hesitant. We see sort of a similar but more fluctuating pattern among African Americans in LA County, with almost 1 in 4 that are quite hesitant as of the end of April. And a bit of a different pattern in the white population in LA County, where there's been a fairly low level of hesitancy. A lot of these folks have now gotten vaccinated, and the folks that are left are really quite hesitant. And so what this means as of April is that we actually have fairly high rates of hesitancy across these populations among the people who are yet to be vaccinated. And so a fair bit of work to do with all of these groups. I'm going to show a couple sort of walls of bars, but I'm going to talk you through them just to pick out some of the key findings. This is just giving us a little bit more insight into, among these groups, among Latinos and whites, we didn't have a large enough sample to break this down for the African American population. Who are the folks that are the most hesitant? And what these graphs represent is that same question: how likely are you to get vaccinated for the coronavirus? 1 is very unlikely and 4 is very likely. So the mean of 3 here is in the somewhat range. And what we are seeing is, and we've seen this since we started tracking this data, that females are consistently more hesitant than males, that there are age differences, but these vary based on race and ethnic groups. So among the Latino population, younger adults are more hesitant, whereas among the folks in the white population who are yet to get vaccinated, it is the older folks who are more hesitant. And we've consistently seen that lower households with lower annual incomes have been more hesitant. The last couple of slides just point at, I think, a few indicators of differences in beliefs that might be explaining some of these different vaccination rates. This first question is about access. And do you think the vaccine is currently available for people like you in your community? You can see here from February to April that there was a big shift up in people that thought they had access to the vaccine, and really a leveling off across race and ethnic groups. But we still have that orange bar, like a fair share of people in all of these communities that feel like they don't have access. This represents people thinking about benefits and risks. So they're asked, how much do you agree that the vaccine is useful and effective, has harmful side effects, and might lead to illness and death? And this is the percent that agree or strongly agree with these statements. And so when we look at that first column, a lot of people see the benefits. They think it's useful and effective, particularly the white population. But when we look at the risks or the downsides to getting vaccinated, we see the highest level of perceived risk among Latinos and African Americans. And so if you think of this as a risk-benefit trade-off, you can see that that trade-off looks pretty different for the Latino community relative to African Americans. This one is talking about government trust and trust in the process that the government has used to get the vaccine out. And I think this parallels what Catherine shared before, that we see much less trust among Latino and African American populations relative to white. And the last slide that I think touches on the comment that Catherine made about the importance of social norms. So this is data back in March. This question hasn't been asked since then, but we have seen really even bigger disparities than we see in actual behaviors. We see bigger disparities in these perceptions of, do you think your family and friends are going to get vaccinated? And we think of this as sort of a social signal of what people think others around them are doing. And you can see by the differences on this bar chart that there really is a much stronger social norm, at least around March, among the white population than the other groups. So I will leave it there. And again, I realize I flew through that, and I'm happy to share slides.
Michelle, you're on mute.
Thank you very much, my friend. Thank you very much, Kayla. That was fantastic. Really so helpful as we're burrowing into where should we be thinking about targeting our efforts. While we switch over to the next slide deck, please feel free to reach out by chat to Dr. Kayla Hay and we continue the conversation. So thank you.
Great. Should I get started? I'm hoping everyone can see my slides. All right. So hi, everyone. I'm Sonali Saluja, and I am an assistant professor at the Gare Center for Health System Science and Innovation. And I'm going to be talking to you today about disparities in COVID-19 vaccine hesitancy and testing in Los Angeles. And I worked on this project with Dr. Cameron Kaplan and with support from the WM Keck Foundation. So our objective for our research project was to examine racial, ethnic, and income-based disparities in Los Angeles in COVID-19 testing and barriers to testing, in access to routine care during the pandemic, and in COVID-19 vaccine hesitancy. We actually added on that third aim due to the timing of our survey, but I actually want to probably focus more on the testing, because I think Dr. De La Haye presented much more recent data on hesitancy that's probably more informative. But I'll share what we've learned for AIMS 1 and AIM 3 with you today. So to do this, we conducted online cross-sectional surveys of nearly 2,000 LA County adults in December and January in Spanish and in English. And just to give you some context of the timing here, December and January was right after the vaccine was authorized and really at the height of the local pandemic when things were really bad here. We recruited our participants using Qualtrics market research panel of volunteer survey respondents, and we did oversample from all racial ethnic minority groups. So these were the questions we asked related to vaccine hesitancy. And we tried to be really careful with the wording of this question. So we said, would you be willing to get the COVID-19 vaccine once it's available? Some surveys ask, would you get it? But we added this willing term because some people maybe thought they wouldn't get it even if they wanted to get it. So, and then we defined hesitant as people who said no or no, probably not, or no, definitely not to this question. And then we followed up with asking people about whether they would be willing to get why wouldn't they be willing to get the COVID-19 vaccine if it was available, with these answer choices. So I'm going to kind of go quickly through this, but really what we found is very consistent with a lot of the national survey data and the data that Dr. De La Haye presented. We found that, you know, even after adjusting for a lot of the known predictors of hesitancy and things like access to care and other sociodemographic factors, that racial ethnic minority, that Black and Latino residents were significantly more likely to be hesitant compared to white residents, so 3.4 and 2.2 times more hesitant respectively. Similarly with income, with people in the lowest income group, again, after adjusting for other predictors of hesitancy, people making less than $20,000 a year were twice as hesitant to receive the vaccine compared to people in the highest income group making over $100,000 a year. But one kind of unique thing that we found in our survey was that people who had very little or no confidence in doing things online were much more likely to be hesitant than people who were very confident. So for those who were a little confident were 2.7 times more hesitant, and those who were not at all confident were 3.3 times more hesitant than people who were very confident. That's again after adjusting for other predictors that I described. But it's kind of important to note that, you know, even at that time in December and January when the vaccine was introduced, only 28% after waiting, 28% of LA County residents were hesitant then. And within that group, 60% of the hesitant individuals said they would probably, as opposed to definitely, not get vaccinated. So I think this, you know, tells us that there's room for progress, especially with the numbers we're seeing now. We haven't reached everybody who we could potentially. When we asked people why they were hesitant, the number one reason that we saw was that people were worried about COVID-19 side effects and safety. And then the second reason was actually that people wanted to wait and see how it works first. We saw some kind of differences by race ethnicity here, not a lot, but we did see, and again, consistent with national data, that Black residents were more likely to say they didn't trust the government in the development process, and both Black and Latino residents said they wanted to wait and see, you know, how it worked first. So I'm actually going to skip this slide. I want to kind of shift to talking about some of the information we learned about COVID-19 testing. And I think it's important because it may hint at some of the structural barriers that people are still facing with regards to getting vaccinated. So we asked, this graph here is showing data on access to COVID-19 vaccine testing by race ethnicity. And all of the comparisons here are to a reference group of white residents. So we asked people if they had ever had a COVID test, and we see that actually Asian residents were significantly less likely to have ever been tested. Black and Asian residents were also less likely to have received the test within 2 days, the results. And then all racial ethnic minority groups were less likely to have had a blood test. And then conversely, Hispanic residents were much more likely to have, significantly more likely to have tested positive for COVID-19 compared to white residents. So really we're seeing a disconnect where the group that was most likely to test positive did not have higher, significantly higher testing rates compared to whites. And that's probably represents, you know, an under testing in the community. So when we asked people, well, what were some of the barriers that you experienced to testing? One of the most common barrier was actually that people were worried that the wait times for testing would be too long. And actually, you know, timing, the time it took to get things done was really important to people. So people said that they were worried about getting their tests back in time, that they couldn't get an appointment in time. So time was a big issue. But another interesting thing is that, you know, over 20% of people said they were worried that they wouldn't be able to pay for a test. And this is in the context of, you know, the county having free testing available for people. And then lastly, a lot of people also said they didn't know where to go for testing. In terms of the disparities that we saw with barriers to testing, Hispanic residents were more likely to experience 2 or more of these barriers. And the barriers that have yellow arrows are the ones where they experience significantly higher rates of those barriers compared to white residents. So they were more worried about testing staff speaking their language, worried about wait times at testing sites, worried about giving their personal information, again, paying for a test and then not knowing where to get tested. And then we also asked residents where did they go for testing, and it looks like free drive-through testing sites were really the most commonly used, but then second after that were doctors' offices and clinics. We did observe that all racial and ethnic minority groups were more likely to use the drive-through testing sites and less likely to use the clinics or doctors' offices. And similarly, lower income people were less likely to use the doctor's offices and more likely to use schools or colleges and universities. This was kind of an interesting thing we found. We asked people if they were able to take time off work while waiting to get the test results. And we actually had 3 options they could choose from. They could say they would be able to get paid time off work, unpaid time off work, or just no time off work at all. And here what we see is that all racial ethnic minority groups reported they were less likely to be able to take time off works compared to white residents. And here you can see in the lower income groups, as many as 25% in those making $20,000 to $50,000 a year said they could not take time off work while waiting for their test results. So I think, you know, putting kind of all this together with the current data that's out there, there's a few key messages. One, I think, is that, you know, the minority of hesitant individuals are definitely not willing to get the vaccine. This is kind of what we're seeing with the national data. It's 18%, but in Los Angeles, it's actually only 11%, which I think tells us that we have work to do, and we can hopefully get there. Also, you know, I think technological barriers are probably playing a significant role in hesitancy, and I put hesitancy in quotes because, you know, it may be that people you know, are thinking that they can't get the vaccine simply because they just can't handle the sign-up system for getting the vaccine. So really, there's ways that we need to find to make getting the vaccine easy, in addition to addressing the community concerns that are being brought up today. And this could include things like, you know, policies to allow time off work for vaccination. In fact, there is a policy, but it's not really clear how well this policy is known or enforced. Again, thinking about investing in vaccine navigators who can work with people over the phone or in person and help overcome that digital divide. You know, utilizing clinics and healthcare providers who can also do things like outreach to the most vulnerable communities. And I'll be honest, I talked to so many healthcare providers who really just haven't received guidance on how to counsel their patients, even though their patients are looking to them for that guidance. And then lastly, things like creative solutions like mobile vans and rewards, things that we'll probably be talking more about in our discussions today. So with that, I will feel free to ask questions in the chat, and here's my email, and I will leave it at that. Thank you.
And last, we'll hear from my hero, Dr. Dang.
Michelle, hi everybody. So in my session, I'll be talking a little bit about the work that we were doing with the city of Los Angeles and the COVID-19 vaccines. And you can see here, I'm going to share my slides. You can see here on the slides all of the amazing partners that we've worked with. So a really great example of the public-private partnerships and the effective work that could be put in place. As we were having some of the other speakers talk, I realized I had some duplicate data, so I'm going to just breeze over those really quickly, but we'll re-emphasize some of the main points here, starting off with data from Los Angeles County. As of yesterday, there were 9 million doses that have been administered, with 5 million going to residents age 16 plus with at least one dose, and then about 1.1 million is 65 years older with at least one dose. So you can see there's still quite a bit of work to do, even though these are really great, amazing numbers. And there definitely is an age gap as well that some of the comments in the chat have referred to. This is the map that you saw earlier as well, just really highlighting some of the areas in brown and tan. Those are the areas that have the lower vaccination rates at 15 to 30%. And those are really concentrated in kind of the Antelope Valley and Southeast Los Angeles areas, while the West Los Angeles, South Bay, and San Gabriel Valley have fairly high, upwards to 60, 70, close to 80% vaccination rate in some of those communities. Definitely highlighting some key disparities there. And on the map to the right, you can see all of the 755 locations where people can get COVID-19 vaccines, whether it's a city or county site, hospital, pharmacy, clinic, a doctor's office, or whatnot. And you'll also notice that some of those areas with low vaccination rates have no vaccination clinic sites in that area. As far as the race and ethnicity breakdown, there is a pretty big disparity that is found in a lot of the underserved groups that have already been mentioned. So in our Black, African American, Latinx populations, especially in the young adults within those groups with 39 and 44%, while all of the other groups having 60, 70% vaccination coverage. So just kind of highlighting all the work that we still have to do and re-emphasizing some of the messages that were already delivered by our other speakers earlier today. For the rest of my session, I will be talking about the work that we've been doing over the last year with the city of Los Angeles through the USC School of Pharmacy. So I like to put everything into perspective. And as I was putting this together, it really helped me put things into perspective as well. When we're living through it, it kind of went by really quickly, but I think it's good to take a step back and appreciate where we've been. So as a summary, COVID-19 was identified in the United States in January of 2020. And then in the months that followed, we had several entities declare public health emergencies. We experienced stay-at-home orders, shutdowns. And for the months of March to June, the nation and the world was really focused on shutdowns, COVID-19 infection precautions, and a huge focus and emphasis on testing. Also during that time, the CDC had recommended pausing all routine clinical and non-urgent clinical care, which many of you are familiar with. So during that time, many outpatient facilities and clinics and offices were closed, and patients were not receiving their routine care. Beginning in June of 2020, the CDC updated its guidance to allow the resumption of non-COVID clinical care, which was really helpful because we were really concerned about the upcoming influenza season at that time. And we were worried about what many people were calling the twindemic, potentially experiencing both COVID and flu outbreaks. So what we did with the USC School of Pharmacy is the city of Los Angeles began reaching out to us in July of 2020 to have discussions about their pre-planning for the COVID-19 vaccine. So even early on, the city of Los Angeles was thinking about what can they do to prepare for COVID-19 vaccines. And in our discussions, we talked about doing a pilot program with the influenza vaccines. We pointed out that this upcoming winter season, people would still need to get their flu shots. We do want to avoid the twindemic. And the USC School of Pharmacy has experience running mobile pop-up clinics across Los Angeles prior to the COVID-19 pandemic. So in September 22nd of 2020, we officially launched our Los Angeles City Flu Clinic pilot, where we did provide free influenza vaccines to Angelenos through our mobile efforts. As that was ongoing, we started hearing more about the potential of a COVID-19 vaccine being released. And so our pre-planning became a lot more intense. But at the same time, recall that there was not a lot of information or any information available at all about what vaccines we would have, what the efficacy, safety looked like, let alone what the storage considerations would look like. And we really all saw that data for the first time on December 11th, when the EUA was granted for the first COVID-19 vaccine, which is Pfizer. Coincidentally, our flu clinic pilot was scheduled to end and take a winter recess on December 19th. So that gave us the late weeks of December to really start digesting the information from the COVID-19 EUA and start retooling our flu clinics to have COVID-19 vaccine clinics. So just a summary of our efforts with the influenza pilot clinic that we did in late 2020. Over 14,000 influenza vaccines were administered at city-run sites. And you can see here the progression of those vaccinations over time. As I mentioned, we did take a winter recess on December 19th. And originally the plan was to restart and resume in January with influenza clinics. However, since the COVID-19 vaccine had received authorization, we quickly retooled those resources toward focusing on COVID-19. What we learned from the influenza pilot clinic was that the mobile units were very effective in reaching certain populations. So here's a demographic data of our patients who had received the flu vaccine through our efforts. 64.7% were Latino, and more than half, 56.5%, had no insurance or they weren't sure of their health insurance status. And an additional 19% had Medi-Cal or Medicaid, indicating potentially reaching low-income populations. These efforts were not as effective with reaching African-American Black populations. We only had about 2.5% patients in this group who did receive influenza vaccine. So taking those successes, we, again, like I mentioned, retooled all of our efforts and focused completely on COVID-19. And as you'll recall, I said that the Pfizer vaccine received its EUA on December 11th. When that vaccine had received its authorization, the federal government had focused the first few weeks solely on nursing homes, long-term care facilities, and acute care hospitals. So these vaccines were not yet available to the public in a meaningful manner. So with the city of Los Angeles, we launched their first COVID-19 vaccines at the Los Angeles fire stations on December 28th. That was the first time the city of LA had received possession of the vaccine. And then we shortly after helped launch the nursing home program with the city on December 29th. But more importantly, on December 30th, 2020, we launched the city's, and I think the state's, very first public vaccine point of dispensing or pod site located at Lincoln Park near the Health Sciences campus. And that was the first public, non-hospital based vaccination clinics that healthcare workers would be able to receive vaccinations, as they were the only ones eligible for the vaccine at that time in phase 1A. From there, the city quickly expanded its number of sites that it offered, and most notably on January 15th, the city launched the mass vaccination clinic at Dodger Stadium, which became the largest vaccination site in the world at its peak of administering 12,000 vaccinations per day. As we progressed throughout the months, the city also launched its mobile vaccine programs called MOVE for the COVID-19 vaccines on February 18th. It opened its vaccination site at the USC University Park campus on March 4th. And on March 6th, we hit an important milestone of delivering 500,000 COVID-19 vaccine doses at our city-run sites. And then they continued to open more sites with a focus on South Los Angeles, with the newest vaccine site located at Southwest College on April 6th. And then the city of LA also took over from FEMA the operations at Cal State LA on April 13th. Shortly after, we hit a very important milestone. On April 15th, we delivered 1 million vaccine doses at city-run site. So you can see that that was a huge exponential increase. It was only a few weeks before that we were at 500,000, and we were able to hit 1 million on April 15th. Another important milestone was, as of April 30th, appointments were no longer required. So we were taking walk-ins, and people could come without an appointment. And then very notable yesterday, Dodger Stadium closed permanently its vaccination site. So it's achieved its mission. And so the city of Los Angeles has closed Dodger Stadium as of yesterday. And the future plans, when I made these slides last night, were TBD, but the mayor has announced new plans this morning that I can now announce. We will be closing all of the fixed public sites over the next 2 months and transitioning over all of the efforts of mass vaccination clinics into exclusively mobile vaccinations. So they'll be expanding their mobile vaccination operations. So here's the progress of our COVID-19 vaccine clinics with the city. To date, 1.3 million vaccines have been administered at our city-run sites and programs. And then specifically, these were our USC School of Pharmacy supported sites at Lincoln Park, Dodger Stadium, Southwest College, USC, and Cal State LA. And if you're interested in looking at the daily progress of the different sites, you can see here, as I mentioned, Dodger Stadium at one point was doing 12,000 vaccinations per day. And as of the last 3 to 4 weeks, the demand has significantly slowed down. So if you are able to look at the chart here, you'll notice that there's been a significant decrease in the number of daily vaccinations that have been offered. And that is why it is really important to discuss strategies to start tackling the population who is vaccine hesitant. That is going to be a really important group to start giving access to COVID-19 vaccines. So some of our strategies across the city-run programs to increase vaccination so far, we have expanded a number of sites. At its peak, we had, I think, 12 public fixed sites and 15 mobile units that were available. We also had multiple models for our public vaccination sites where we had walk up, drive up, and drive through so that people could use public transportation, take their own vehicles, or whatever their preference might be. They also opened a call center with health navigators using a helpline for those who didn't have access to internet or computers. As I mentioned, they roll out their mobile vaccination units. And at the very early stages, the mobile vaccination units were exclusively for underserved communities. And those mobile vaccination units were doing walk-ups only, no appointments, because what we wanted to prevent was people from West LA making an appointment to these mobile units, taking up valuable resources from the local community. So the city worked with the local council districts and local community organizations to have invitations and information spread out to the neighborhoods where the vans would be located. There were also rideshare partnerships to provide access and transportation to vaccines, express lanes for access services for those who had disabilities. The city also launched a homebound program where they provided vaccines in the patient's homes if they were unable to leave for whatever reason. They also launched the homelessness or unhoused residents program. And as I mentioned, we transitioned to no appointments. And as of last week, we now have expanded evening hours, offering vaccinations 8 a.m. to 8 p.m., recognizing that some people may be working during the business hours. And if we were only open 8 to 5, that it would be inaccessible to that population. So that's the work that we did, and I'll pass it back to the program.
Terrific. Thank you so much. Well, every one of those presentations were fantastic. They really helped to set the stage for where we go next. So I'd like you to just imagine yourself virtually stretching and walking. You'll be walking into a breakout room. We do have 2 breakout rooms. The first one is going to be focused on sources of vaccine discomfort and hesitancy. The second is going to be focused on strategies to address hesitancy and reduce barriers to vaccination. In each of these breakout rooms, we will have a facilitator, and one of our partners with Wondrous will be facilitating the discussion. And I would really encourage each of those facilitators to do a very quick introduction of Wondrous and the role that you're playing. We will also, in each of those 2 breakout rooms, have a recorder. So someone who will be taking notes and will be able to report back when we all come back after these breakout rooms. I would like to ask that each presenter give a very brief introduction of themselves. And then here's the real trick. We're gonna ask you to do this, like speed dating, a 3-minute presentation. And really, this is sort of to wet folks' whistles. Because we really want to make sure that there's lots of time in those breakout rooms for discussion, both in terms of thinking about what the implications of what you've heard are, and also what are some recommendations for what we can do going forward in the future. Now, here's the other thing that's just going to be sort of fun. We are randomly assigning you to one of those two groups. And so it'll be sort of fun to see who ends up in which of those groups. The reason we're doing that is because we really want a mix of perspectives and expertise in each of those rooms. Now, if you get into that room and you're just not happy with where you landed, that's okay. You can pop out of that room and we'll put you in the other one. So don't feel bad if you feel like you didn't get the right one. And I think with that, I'll just go ahead and say, take that stretch as you wander into the breakout room. Claire's going to actually lead you into the room. I think you're going to get a prompt that says, yes, take me into the breakout room. And then when we reach the end of the period that's been set aside for the breakout rooms, you'll see a little sort of countdown with how much time you have left. And then we'll all come back together. We'll do that report back, and there'll be some time for additional discussion. So I'm going to wander back and forth between the groups. So I will see you there. Thank you. How are you? So good to see you.
Good to see you too. It's been a while.
It's been a really long time, but not that we've aged. It's just time. Maybe it's a little bit like COVID time. It feels like it's not
I have any
32
more gray
years.
hairs.
Family doing well?
Doing pretty well. Michelle and I know each other because my wife is was the principal of a school that your daughter, her son, I forget which, went to. But my wife is now the superintendent of a school district, wrestling through COVID, and it's a district that's about 85% free and reduced price lunch, about 90% Latino and Black, really ripped up by COVID. And her job this year has made mine look exceptionally easy.
Yeah. Well, she always wanted to, that's the district she wanted to lead. And I'm still on the school board in South Pasadena, so I know exactly what she's been experiencing all year. So anyway, good to see you. So I'm going to hand this over to who with Wondrous is leading this group?
I'll be facilitating. Lyric here.
Great.
Okay, well, thank you everyone for joining, and thank you, Michelle. I'm a researcher or design researcher with Wondrous, and Wondrous is a creative agency, and we work to develop creative campaigns to inspire social change. So for these breakout rooms, I'll be your facilitator. And just for some quick housekeeping, I'm going to introduce our presenters momentarily. And then in the interest of time, if you could in the chat, share your name and your role. And then as we move into the discussion portion, if you could just share your name again before you speak in our discussion, that would be great. So I will now pass it over to Dr. Rachel Caesar, if you'd like to introduce yourself.
Hi, everyone. Good afternoon. I'm Rachel Caesar. I'm a medical anthropologist, and I am in the Department of Preventive Medicine at Keck. I'll also be presenting with my colleague, Damaris, who also supported, who did data collection and analysis with me and helped put together some of our slides.
Okay, great. Thank you. I can pass it over then to Dr. Excuse my pronunciation as well, Kaidi Hay.
Hello, good afternoon, everyone. I'm Katie. I'm one of the CHLA Infectious Diseases Fellows.
Okay, great. Thank you. And if I could pass it over to Dr. Wael Al-Ghamid. Again, excuse my pronunciation.
Close enough, no worry. My name is Wael Abdelmajid. I'm a research professor at Viterbi School of Engineering.
Okay, great. And then we have Dr. Yan Liu as well.
Hi, everyone. This is Yan Liu. I'm professor in computer science department at Viterbi School of Engineering.
Okay, thank you so much. And then Laura, did you want to also introduce yourself?
Oh yeah, hi everyone. I'm Laura Stoddard. I'm the project manager working on Vaccinate LA with CTSI, and I will be taking notes on our discussion today.
Okay, great. Thank you so much. And I think with that, we can probably go ahead and jump into our first presentation by Rachel.
Sure, Rachel, I can share your slides unless you'd like to pull them up.
Yeah, if you could share, that would be great. I have an older computer. It gets a little hot at the end of the day, so I appreciate that. Thank you, Laura.
Can you all see that? Cool. So Damaris and I will talk a little bit about what we found in our research, our qualitative research on vaccine access in the LGBTQI community. Next slide, please. Oh, thank you. So just real quick, we had 5 focus groups, about 33 people, and we talked to service providers, sorry, that's incorrect, service providers in the LGBTQI community in Los Angeles. And our goal there was to identify barriers and facilitators to vaccine uptake in those communities. And then in terms of community objectives, to really try to identify potential opportunity areas to improve COVID-19 vaccine delivery and ensure that the delivery services that we propose based on that data align with the unique health needs and values of the LA LGBTQI community. Next slide, please. So kind of 3 big findings were, 1, we saw that barriers to the vaccine were most harmful to trans people, LGBTQIA aging adults, and to people experiencing homelessness in that community. The second thing we found was that what we heard was that structural competency really needs to be an integral part of of medical education, particularly around vaccine sites and vaccine staff, in order to better serve the LGBTQI communities, but especially those communities of color. And the third thing we heard was there really needs to be better LGBTQI representation in terms of developing vaccine programs that reflect those lived experiences, you know, from the very beginning at every step of the way. Next slide, please. So I'll just go a little bit over kind of our key insights within those 3 spots, 3 areas, and then quick quotes. So what, you know, when we were asking who is most impacted by vaccine barriers, we heard, you know, we heard a lot about violence against trans people, which creates fears to getting the vaccine. So we heard someone say, you know, people are afraid that they're going to be beat. This fearlessness for their lives. Trans women are being attacked in Hollywood and LA. They are afraid to come out of their homes to get the vaccination. Next slide, please. One opportunity area we saw here was, you know, the vaccine needs to complement people's lives and offer more than survival. We heard survival come up all the time for this community. We also heard to please create incentives to getting that vaccine. People's made some comparisons to HIV. You put $25 out, say everyone come get $25 and get tested. We don't care if you know your status or not, you know, provide food, provide goodie bags, bring people in instead of creating barriers. And the third thing in terms of opportunity area, to meet community where they are. That means including elders and people experiencing homelessness. Midnight Stroll was an example. Go to where people are at. Don't wait for them to come to you in terms of the vaccine. Next slide, please. The second insight was, well, what do safe vaccine spaces look like for this community? And we heard a lot about getting the vaccine requires trust of the medical system. And, you know, this is a theme we heard earlier in the presentations today, but I think what was unique, what we heard with the LGBTQIA community, it's not just medical trust, but it's for the medical system to acknowledge the historical and current trauma that they have done to this community, and to start from a place of acknowledgement and what that looks like in terms of safe vaccine sites as well. So we heard from a person, you know, everyone at the vaccine site referred to me as sir. Mind you, the medical form I filled out had asked all those questions, but did they read it? No. Was anyone actually paying attention to me as a person? No. So we heard this kind of on the meta level, of the medical system needing to acknowledge these harms, as well as these kind of more logistical specific terms of harm and violence in this community. Next slide, please. So potential opportunity areas in designing safe vaccine sites for the LGBTQI community, that includes, again, as I mentioned, the medical system acknowledging their role in that trauma and that creating that mistrust. So it's not about the LGBTQI community creating trust for them, it's for the medical community to acknowledge how they've created mistrust. Second was, making sure vaccine staff are educated on creating inclusive and welcoming spaces. And to really, if that's not going to happen, then we need to shift the vaccine away from medical sites, is what we heard, and meet people in their communities and LGBTQI communities where people are at. With that, I'm going to pass it over to Damaris, and she's going to briefly introduce herself and then share our last insights. Next slide, please.
Hi, everyone. My name is Damaris Garcia, and my pronouns are she, her. I'm a research assistant at the Children's Hospital in the Community Health Outcomes and Intervention Research Program. So one of the major points we heard is that we need more community representation in every step of the vaccine rollout in order to make people feel safe, affirmed, and seen. Next slide, please. Some of the things that we heard is that this is why we need to let LGBTQIA leaders lead in order to bridge trust between community and the vaccine. Further, when there's more representation of people with lived experiences, then community members will feel acknowledged and safe when getting the vaccine. Thus, based on what we heard, it is crucial that those with privileges use their power to give community members positions of leadership. All right, thank you. Back to Rachel.
Cool. That's all we wanted to share, and welcome any questions or suggestions. We've put a report together. I know that a lot of the people here on the team with Michelle Kipke and Laura, Quinny and Nikki are doing a lot of efforts to disseminate this work to the broader public, as well as working to put something together in terms of peer-reviewed publications, which was important to the people we talked to. Thank you so much. Was that under 3 minutes?
You did great.
Thank you so much. It's great. So I think next we have Dr. Katie presenting, and similar to in our main room, feel free to add some of those questions to our chat as well as we go through these presentations.
Hi, everyone. Thanks, Rachel and Damaris, for such a great presentation. I really enjoyed it. My presentation is going to be on a fellowship project that I've been working on with the ID department. Thank you. Thank you. So I'm excited to be sharing with you about a survey on childhood vaccine hesitancy that we've been working on at CHLA. So we were very interested at the start of the pandemic on understanding the impact of the pandemic on routine childhood vaccine hesitancy. At the start of the pandemic, there'd been a significant decline in the vaccinations due to the stay-at-home orders and a lot of social distancing. And later on during the pandemic, there were multiple concerns voiced about the development of the COVID-19 vaccines. So we were very interested in how all of these factors shaped perspectives on childhood vaccine hesitancy, specifically during the pandemic. The majority of the data that had been published during the pandemic about routine childhood vaccine hesitancy had actually been from data collected prior to the pandemic. And then during the pandemic, there was a lot of focus on COVID-19 vaccine hesitancy in adults. So our interest was really in designing a study in our CHLA patient population, parent population, about the impact of the pandemic on routine childhood vaccine hesitancy. So we studied, we conducted an anonymous mobile phone-based survey of 271 parents at CHLA from outpatient clinic, inpatient floors, and also subspecialty clinics. And we asked parents to answer questions on their perspectives on childhood vaccines before and during the pandemic. And we used a validated survey on childhood vaccine hesitancy. We asked parents if they had previously vaccinated their child before the pandemic, and whether during the pandemic they intended to vaccinate. So we looked at demographic factors which might be affecting these choices for both childhood vaccine hesitancy and COVID-19 vaccine hesitancy. Next slide, please. So in our patient population, we found that the overall childhood vaccine hesitancy increased with increased risk perception and concerns for adverse side effects of vaccines. So our study actually didn't detect any significant change in overall vaccine confidence, and the parents at CHLA from our study actually continued to ascribe really high importance to childhood vaccines and influenza vaccines. We looked at the different demographic correlates of childhood and COVID-19 vaccine hesitancy too. And in our patient population, higher income was associated with decreased hesitancy, and Hispanic ethnicity and African race had increased risk perception. And this was more prominent also in their concerns, more prominent concerns for the COVID-19 vaccine. So we felt that this overall increased vaccine hesitancy and risk perception was most likely associated with some misinformation about vaccines that we know has been spread during the pandemic. And as some of the other speakers had noted, there's been distrust of scientific research and concerns about the pace of the development of the COVID-19 vaccine. That this seems to have been balanced out by a lot of efforts from community health groups like AAP and CDC, who really put a huge emphasis on maintaining the vaccination rates. So it seems most likely that this has also helped in maintaining vaccine confidence. So overall, we were disappointed that the vaccine hesitancy increased over the course of the pandemic, but we thought it was still very promising that vaccine confidence and the importance of vaccines was unchanged, and that the majority of our CHLA parents were still very receptive to vaccines. And like some of the other findings from other speakers, we also found the same thing, that different demographic groups perceive vaccine risk differently. So in the future, we also feel like there may need to be different targeted strategies to as we work to implement the COVID-19 for our pediatric patients. So with that, I'll pass that back on to Lyric. Thank you so much. And I'm happy to answer any questions too in the chat.
Great, thank you so much for sharing. And so next up we have Dr. Weil sharing.
Do you want me to share my screen, or are you gonna share from yours?
I can share it. Let me just pull it up here.
Mm-hmm. Thank you, and thanks, Michelle, for including me. Well, my talk is not directly about vaccines because I don't do vaccines, but it's about misinformation, and specifically visual misinformation. This is something that has emerged in the last few years, and we are seriously concerned about the effect of visual misinformation on vaccines. Next slide, please.
Sorry about that. My computer froze for a second.
That's fine.
Yeah, let me pull it. Not working.
So I intentionally didn't include any vaccine-related images because they might be controversial. I decided to use something more generic. So this is a story about a 10-year-old girl called Sarah, who met basically Jennifer. And basically Sarah told Jennifer that to Miami, Florida. My mom, Beth, and my dad, Peter, moved with me, and I have two siblings, Matt and Noah. And Sarah and Jennifer started basically trying to be friends so that they can meet in the park or something and have a play date. Next, please. So it turns out that this whole story is actually fake, and it's somebody called Mr. Hyde who wanted to basically attract Jennifer to the playground so that basically he can assault her. The problem with this story is that every single character in this story is actually a fake person. As you can maybe you cannot tell from these pictures, all of these pictures, including Mr. Hyde, are actually computer generated. And I basically generated them to convince basically a victim like Jennifer to come to the playground for assault. So this is how artificial intelligence is good now in creating fake personalities and fake stories. Next slide, please. So next slide is, this slide actually should include a video. I don't know if it actually, yes. So let's listen to the video for just a few seconds. This is a video from the Nixon era in the 70s. And he's, is it playing?
Let's see. Should it just play by itself?
Yeah.
Oops.
Laura, you might want to make sure you're sharing sound. When you hit under share screen, under advanced sharing, make sure you're also sharing your computer sound.
Okay, sorry, one moment.
It's fine, take your time.
Also, if you can copy and paste the link from his slides into YouTube or into a browser.
Let's see, sorry, I can't pull the link up. Well, would you like to share your screen? Would that be easier?
Sure, I can do that.
Okay, sorry about that.
No worries, give me a second. So let's listen to the video.
Good evening, my fellow Americans. Fate has ordained that the men who went to the moon to explore in peace will stay on the moon to rest in peace. These brave men, Neil Armstrong and Edwin Aldrin, know that there is no hope for their recovery. But they also know that there is hope for mankind in their sacrifice. These two men are laying down their lives in mankind's most noble goal, the search for truth and understanding.
So I'll stop the video over here just for the interest of time. And as you can tell, this is a completely fake video. It's completely AI generated. And it's talking about a story from the 70s that everybody knows, or at least most people know it's not true. The people actually who went on Apollo 11 actually came back. The problem with this, whether it is the images that I showed earlier or the fake video, are all AI generated. And this technology keeps improving literally by every day. And we have been seeing a lot of evidence on social networks, including Twitter and Facebook and other social networks, is that visual misinformation is actually leading to vaccine hesitancy. As I mentioned, I didn't want to include specific examples because I don't want to be the example to be controversial, but this actually is going on social networks now. People take images and videos of from completely that was basically posted under completely different context. They change it a little bit. They maybe change the text on the signs, and it creates a lot of vaccine hesitancy. So long story short, we shouldn't be basically believing everything we see online. We should basically vet information. Any visual information we see online must be vetted. We need to ask for motives for basically the person who originally posted a given image or a video. what is the provenance of that information. Some of these images are very easy to find if you just do a Google inverse image search, so that you can see where that particular image or video came from. And think if it actually makes sense. If you see something that has to do with vaccine or any other information on Twitter or Facebook or Instagram, we need to think about whether it actually makes sense or not. So thank you.
Thank you so much. So fascinating. And lastly here, we have Dr. Yan Liu who will be presenting next.
Sure. I'll just go ahead and share my screen. Hope that's easier. All right, can you see my screen?
Yes.
Okay, all right. So yeah, thank you for the organizer to invite me, and I'm really glad to talk a little bit about our research work around COVID-19 vaccine. So for the general background, my research area is mostly machine learning and artificial intelligence. One of the applications we've been working on is misinformation on social media. We've been working a lot around misinformation around COVID in general, and today I'm just going to present a little bit about our research work around COVID-19 vaccine. So as we know that social media plays an important role in people's, in informing people's opinions about COVID-19 vaccine. It can influence people's views on vaccine and also its safety and effectiveness. So there has been a lot of misinformation and conspiracies about the vaccine on social media, which greatly increases the vaccine hesitancy and reduces the trust in science and medicine. In this particular study I'm going to show, we collected the social media posts on Twitter. It's not the full Twitter tweets, but basically this is the 1% through the Twitter API. The date we started is on December the 9th. That is actually when the FDA granted the emergency use authorization for Pfizer. And here that we can see that gradually that we're going to see more or less tweets around over different time. And among all these tweets, and sometimes we're going to see spike. For example, when we talk about Moderna tweets, then it increases when they actually releases the authorization for Moderna. And then basically that in there that we are trying to do a series of studies. The first thing that we want to do is that we want to analyze the different type of false misinformation and questionable claims using basically a combination of machine learning techniques so that we can detect the fake news in the first place. And then we're going to analyze what type of misinformation around COVID-19. We also are going to use the machine learning model to detect the coordinated efforts who are these malicious users on Twitter to spread the misinformation intentionally. So we hope that we'll be able to identify these type of misinformation, that which one are present, what are the activities, what are the conspiracy theories, and also hopefully further study the potential risk and impact on the general public in terms of how this would actually increase the vaccine hesitancy. So here we show some results. One of them is that basically there is a large amount of misinformation related to vaccine in general. And here we classify them in terms of the 6 different type of categories. One of them is around the scientific facts about the vaccine. For example, they said that we don't want you don't owe anything, including your body. And then this is the disruption of your immune system, maximizing gains for Bill Gates bioterrorist. There's also a large amount of misinformation regarding the side effects They will do a lot of the cherry picking and misleading context in many cases, false claims of the adverse events in connection with the vaccine. And also a large body of those misinformation around effectiveness. They will say that, oh, there's the vaccine still will cause a large amount of infections. They're not useful at all. Obviously, you've heard a lot about the deaths related to vaccine refusals and also the rollout issues. Another thing that we identified using our machine learning model is basically this coordinated accounts promoting the COVID-19 and also the anti-vaccine conspiracy. So in here that we can find some of the clusters of the coordinated group accounts spreading the conspiracy. One of them is actually saying that the COVID pandemic, first of all, is a scam and a hoax, and vaccination is a tool to actually depopulation, or that masks and lockdown are useless. There are also some other political motivated misinformation and also possible coordinated efforts related to a vaccine rollout and also the administration. In the next slide, we show a little bit about the discrepancy and also the discorrelation in terms of what people talk about in terms of the side effect of the COVID vaccine versus what is actually reported in this the CDC virus database. So on the y-axis, on the x-axis, you're going to see what is actually stored in the medical records. And some of the side effects, as we probably know by now, is basically swelling, allergic conditions, fatigue, dizziness. And these are all basically mild side effects. But on the other side, on social media, what you actually see a lot more is about these really serious side effects in terms of illness, and there's also this malignant, some type of disease or autoimmune disease. This is basically, or even death related to the side effect. And also the reinfection and stuff like that. So as we can see that these blue colors, the green colors represented what is actually the frequency reported on the virus database is highly uncorrelated with what is actually talked about on social media. And this discrepancy can also further increase the vaccine hesitancy in the general public when they are more or less exposed to social media. So yeah, with that, I would say that this is a really exciting research topic and also extremely concerning in terms of public health. And I'm aware that a lot of social media companies like Twitter or Facebook are trying all their best fighting the misinformation and malicious groups to diffusing these misinformation, but the battle is never ended or has not ended or even just started. So I just want to raising this huge issue and awareness. Yeah, thank you.
Thank you so much. And thank you to all of our presenters. And so we have a little bit under 20 minutes and we'd like to get into a discussion around sources of vaccine discomfort and hesitancy. So feel free to unmute yourself and contribute to the questions. And you could also make a note in the chat if you'd like to answer one of our questions. So our first question for our discussion is, what are the top 3 issues that need to be addressed to encourage vaccination? And again, this is centering around sources of vaccine discomfort and hesitancy.
Lyric, it looks like Dr. Pastor has raised his hand.
Oh, great, Dr. Pastor, you can go ahead.
Yeah, it wasn't, it's partly in reaction to that question, but I'm an academic, I can manage to work whatever I wanted to say into whatever question you just asked. But one of the things that, at least anecdotally, seems pretty important is the lack of legal status for so many people in Los Angeles. We calculated as part of a report, No Going Back, which came out in September, that 18% of the county is either undocumented themselves or living with an undocumented family member. And there's a lot of anecdotes of people being asked for identification at pharmacies, not I think at the pods or in the mobile or community clinics, but that creates a lot of fear because of all the other intersecting risks that will be incurred if one's documentation status is revealed. And I think it's a public messaging thing, but it's also the case, there's that, for both people doing community engaged research and community safety / policing, it takes years and years to build trust, and it takes one bad story to erode it. And I think that's out there, and that at least partly there's other factors too, but I think it's an important factor in explaining the Latino lack of vaccinations and should be lifted up more importantly.
Absolutely. I think that's definitely an excellent point. And I'd like to open it up to the group as well to add to this list of barriers that the community is facing for vaccination.
Oh, this is Rachel here. Just to add to Dr. Pastor's point, Damaris and I heard this in our research as well with the LGBTQIA community, that there is this balance and just frustration among service providers. So in terms of collecting data, that there's a push from departments of public health to partner with organizations. They say, hey, we're going to give you some stuff, free vaccines, or so you can disseminate this on your own, or, some kind of services to support vaccine. And then they say, okay, we'll give you these free services, but then as an organization, you need to collect data. You need to collect all this data, so much data, especially when people feel vulnerable in terms of, as Dr. Pastor mentioned, of documentation, of my gender orientation, et cetera, all these other things I need that we heard from service providers. They have to collect so much data that they end up having to hire somebody else and fill the position, and all the kind of logistics that come along with that, and the financial burden. So we heard a lot from our service providers that Damaris and I talked to in the LGBTQI community, like, just this is an emergency. This is a time when we need the vaccine. We need to disseminate it among our community. Please don't ask for any data. We just need to do this, which is challenging, as a lot of us have heard in other presentations today, of like, we also want some of that data, so we make sure we're reaching we're not missing anyone. So it's a difficult balance.
Yeah, thank you. I think another excellent issue to address. So far we're hearing lack of legal status as a barrier, significant barrier, as well as this trade-off of data collection in order to have some of these resources or incentives to get folks in for vaccination. So do we have another, top barrier that we want to prioritize in this list of our 3 ongoing barriers for the community? I see Dr. Weil with your hand.
Yeah, I think one of the barriers, which might not be related to the Los Angeles area specifically, but globally, is vaccine misinformation and disinformation and lack of trust in science. I don't have a solution to that, because even for the work that we did in terms of detecting visual misinformation, we actually present evidence that a particular image or video is manipulated and you shouldn't trust it, but people still think that we manipulated the evidence. I don't know what the solution is, but I think it's I think misinformation and disinformation and lack of trust in science and government is a big barrier to embracing the vaccine.
Great, thank you. So just to kind of recap our three issues that we're seeing right now, we have lack of legal status, this data trade-off to get incentives, as well as misinformation that people are seeing surrounding the vaccine. And so I'd like to kind of move into what are some recommendations or some strategies that can help alleviate some of these barriers that we're seeing.
I think one of the ones that one of the ones that we thought about when we were discussing with our participants is if we didn't have to request an ID, so not requesting to use a California ID, because sometimes, whether it's because of your documentation or whether it's because your ID doesn't align with your identity, it becomes a barrier. So why not eliminate that and not necessarily put California ID, which scares a lot of people, but just any type of ID that can an undocumented person can have or can show without it revealing, because a California ID has a particular area that differentiates a person who has Social Security versus someone who doesn't. And so we can ask for a school ID or any other type of ID that can have a person's name that they feel comfortable sharing without having to share their citizenship status or having to share their dead name, I think would be a great way to invite people to feel more comfortable.
I think that's a great idea. And one thing I would also suggest, because we know the whole trusted messenger thing, is that a combination of faith leaders who are important in the immigrant community, both Catholic and Protestant, DACA recipients who could be hired legally, and then trying to create mechanisms such as grocery cards and other things to pay undocumented, develop undocumented promotores to be able to be ambassadors for the vaccine. Because I think that, everything everybody is saying from the research is that the more the messenger looks like you or is similar to your situation, the more you're likely to receive and believe the message.
Yeah, I definitely, those are both, I think, excellent, solutions to trying to work through some of these barriers. And we're interested too in kind of with that trusted messenger, what are, people's communication and information preferences to receiving some of this information surrounding the vaccine. So we're interested to hear a little bit more about who that messenger might be in different communities, including the Latinx community, African Americans, as well as the youth community. And then, what form that communication might look like. Is it digital? Is it physical? And where might they receive this communication?
I think in the doctor, community healthcare provider side, we're really making a huge effort to work with the pediatricians and primary care pediatricians, because in a lot of subspecialties, we can emphasize the importance of the vaccine, and it'll help communicate it to our different patients. But because we don't have the trusted bond, it's sometimes a little bit less effective than having the primary care pediatrician deliver the news, because they've been seeing the patient for years and years. So I know in infectious disease and in a lot of other divisions, we've, during the pandemic, really worked hard to establish some more networks with the primary care pediatricians. There have been multiple online social media campaigns by American Academy of Pediatrics and a lot of the healthcare community organizations. And they've really made a huge effort to text parents and also have all these recall systems where the parents can get their questions about the vaccines answered. So I think they're, I think, one of the strongest resources for helping develop the trust with parents for pediatric vaccinations.
Jared speaking. I'm just going to jump on to what Heidi was just saying and say that I think it's, yeah, empowering the physicians, but also other ancillary like healthcare staff, including the nurses and other providers. So your techs and all those people to feel empowered to give some education about vaccines and catch the patient in different parts of their visit. And that's something we're trying to do in the ED, and actually do an iLearn module that I'm going to create with the nurses about empowering them to educate on flu vaccination is what my focus has been on for research, and giving them that, you know, feeling that, you know, it's okay to talk to them about vaccines. It doesn't have to be just the provider. So I think trying to reach them at those different levels.
Great. Yeah, I think those are both great insights in terms of empowering the healthcare community to share to their patients. And I would also be interested to hear a little bit more about, you know, maybe what are some additional communication methods for folks that have hesitancy or might have hesitancy around visiting a provider.
I'm not sure if what I would suggest in the following will directly align to that, but I think that one of the common methods that for e-commerce to use is actually approaching the influencers on social media. And what they do is basically they pay influencers on social media, but maybe since this is for public health and social good, maybe there's some way that we can align some of the social influencers online so that to broadcast the correct message and to encourage people to take the vaccine. And because a lot of time that the influencers can have a huge penetration to the population that many of the doctors, healthcare clinicians actually have access to. So just some food for thoughts.
Yeah, definitely.
Oh, I just wanted to push back a little bit on the influencer, at least what we heard. We heard different things from service providers in the LGBTQIA community. We heard some like, well, why should we trust an influencer who doesn't look like me, doesn't represent me, is not from my neighborhood, and is getting paid to say this? And they actually said this about physicians as well. They're like, okay, I'm Latino and that's a Latino physician, but I don't know them. So like, you know, there's some things of class and access there too, perhaps. We also heard, you know, like it'd be, you know, in terms of this theme of like survival, like we're surviving in this community, like we're just trying to do that. And now you also want us to, you know, also be vaccinated, and the challenges around that being an LGBTQIA person. We also heard like, wouldn't it be nice to see trans celebrities or trans athletes looking healthy and surviving, and not just surviving, but thriving? And what might campaigns look like there where LGBTQI community is better represented?
Yeah, I would like to respond to this in the sense that when I say influencers, I'm not saying that the top influencers for that are well known. I'm talking about the influencers that influencing the community that we're interested in reaching out. So yeah, I agree with your concern that, okay, if some celebrity that's saying something that I personally don't align with, I won't trust, that's for sure. But if this is some scientist that I very much, Dr. Fauci, right, and then I will trust him. So I think finding the correct influencer is really the key, instead of just saying, yes, it won't work, or yes, it will work.
Thank you, that's helpful. Thank you. And just looking at the time here, just wanted to let everybody know we have about 2.5, 3 minutes left.
I think actually, sorry to jump in, I think we might extend by a few minutes. So we might have a little bit longer. Yeah, just waiting to hear how long.
Okay, sure. Sounds good. And so with these messages, I know we talked a little bit about, you know, who people might like to hear from, and whether this might be something that is on social media or that you're getting directly from your provider. And so are there any, you know, key messages that should be included in these different types of communications, in your opinion? And how might that message change, you know, based on who the messenger is?
You know, one group we haven't talked about as explicitly as we might is young people. I've got a 34-year-old son and a 31-year-old daughter. 34-year-old son was eager to get the vaccine, was able to somewhat quickly, because he caters on Hollywood movie sets, so it made him a food worker when that opened up. My daughter, who actually works in a group home and could have been vaccinated very early on because there was COVID running through the group home, and it dovetails with one of the early categories, has still not been vaccinated. And part of it is, you know, hippy-dippy organic health stuff. Part of it is not trusting the government broadly. And I think that I don't think she's the kind of person who thinks she's indestructible. I'm sure there's that with young people too. But I think that low youth vaccination rate is something to be of concern with, because we imagine that's a group you could reach with information. So can you all get my daughter vaccinated is really what I'm asking.
Yeah, I think that's an excellent point, and thank you for sharing your, you know, personal anecdote there as well. And so I think it's interesting. We might think of it in this way to help frame our thinking of how would we, you know, go about as not trusting government, or maybe thinking you're indestructible, or not trusting the efficacy of the vaccine.
I think a problem that we had also, segueing from what, building from what you were saying, I think in the beginning, a lot of the vaccine hesitant, at least parents in our clinics, were not able to reach them just because they weren't even coming in for clinic. So I think one of the things in the future for us, like going on, would be to be able to reach out to people who really don't see their healthcare provider as much, because in the ones who see their healthcare providers and are able to come face-to-face to clinic, those parents seem actually more receptive. So what we really need to do is reach the parents who, or the adults who are not coming into clinic, because they're, at that point, they're getting their information from, sometimes, like a lot of times, from online. And I found that after talking with them, they have a lot of more concerns that we aren't able to address at the moment.
And with some of those, you know, that information that they're receiving and stirring up some of those concerns they may have, are there any particular sources that people are hearing in terms of where some of this information is coming from? I'd be interested if anybody has insight into that.
So when we were doing the focus group for our survey at CHLA, we were hearing a lot of misinformation from Facebook. One of the common themes was in the parent focus groups, people would say that in the Facebook groups that they would be hearing about 5G networks, and this was back in July, August, way before the vaccine was widely available. But I think Facebook, Twitter, those, and a lot of news networks, especially during the pandemic, because at that time, people were hesitant to come into clinics, so they weren't able to access their healthcare providers. A lot of times they heard a lot of different things on the radio or over the internet, and they were getting their sources there.
Yeah, and I think you bring up a really interesting point there too with some of these social media networks, and thinking about, you know, what are messages that we might be able to disperse through online forums to dispel some of that information.
Not in the study we presented, but we're doing ongoing research with promotores across California. And we heard that there's a lot of misinformation in the form of memes, you know, through WhatsApp groups. And I could see, you know, they're funny and they're fun to send around, and they circulate very quickly. Much faster and more fun than like the real information. So what we were kind of playing around with the idea with the team, like, what about if there was, you know, similar funny memes that got circulated around, but that information is actually correct? Could be one option to try.
Yeah, I think that's great. And from what you've been, you know, seeing, what do you think would kind of help verify this information in this form of like a meme? Like, how might we go about showing that this is correct and valid information from a trusted source?
Yeah, I'm not too familiar with this area, but like I know like at USC we have, what is it, like Hollywood in Health, you know, where you get people who are professionals in film and also in public health. And what happens when you get them together and they make sure that storylines are put out on TV and movies, that there's no misinformation, and that they are representative and inclusive and have the right message. I could see something like that applied to this context.
I think it's interesting as well, kind of to your earlier point that you had made, Rachel, where you're talking about, you know, having more figures that are from the trans community, from the LGBTQIA community, and, you know, a meme being a very accessible thing where you are able to access some of those figures and influencers. And just so everybody knows, we have about 4 minutes left for our discussion.
We actually have 2 minutes left.
Oh, 2 minutes left. Okay,
yeah,
so we have
3:05 we're
one.
ending.
Okay, we have just one last question then here. So are there any perspectives on whether to approach messaging from a more emotional, scientific, or social political perspective? So from what you all are seeing, what angle, you know, might best resonate with some of the younger audiences, for example? Or is there a balance of all three of these types of messaging?
I think there's probably a balance, but one thing that I'm thinking about is just younger people in general. I feel like are more service oriented, and the idea of a community beneficence and for the greater good, trying to kind of advocate not just that the vaccines for them, but for their parents and grandparents. And I think just anecdotally, I think that could have a positive impact on trying to reach them. But I don't have any data to back it.
I would
Thank you.
I would have pictures of sweaty dance floors and tell people that they can get back to this. Serious, that would move a large number of people. By the way, another thing to kind of take a look at is that some of the fastest adapters of good COVID hygiene and good COVID practices and vaccinations are people who work on Hollywood sets. Because there's a lot of need to do that and to be able to come back to work. And I think there's really something to learn there.
The other thing I wanted to mention is that for people that are still holding out or are hesitant for whatever reason, that we have just anecdotally, I've heard that there are some people that have to pay more to sit in a certain section, in a concert, in a venue. There's a non-vaccinated section. One of my friends was telling me this yesterday. She is not vaccinated, and she said, oh, if I have to sit in another section, that's kind of embarrassing. Or if I have to pay double, which she's trying to go to an event in which she does have to pay double. And she says, oh my gosh, I don't want to do that. So that is really what's incentivizing her, which is kind of silly to me. But anyway, for what it's worth, I think that sort of, I don't want to say public shaming, but sort of somewhat public shaming. Like if you're she's like, I'm embarrassed to be in a different section. So yeah.
Wow, I hadn't heard about that. That's very interesting. And I think with that, we are pretty much at about time here. So thank you everybody to our presenters for presenting those great slides, and for everybody engaging in conversation with us. So you should get an invite to head back to the main room here, and we'll see you there. Thank you.
Thank you all.
Ooh, what a cool group. I know almost every one of you. This is great.
Hi, I need to go to room 1 because I'm presenting in the other room.
Oh, heavens. Diego, do you know how to get her to room 1?
Yeah, I will. Let me see if I can message Swail since she's in charge of.
I think you can just leave this breakout room and then you'll be back in like the lobby, and then you can ask them.
Okay, great.
Yeah,
Thanks.
if you click leave room.
Yeah.
Yeah, I think I'll bring you to the main room. Yep.
Kayla and Richard, that was excellent. Thank you both. So Richard, where are you going now? Disneyland?
I actually do have tickets to go to Disneyland soon.
Awesome, everyone. Well, I think I can kind of hop in and get us started. So my name is Diego. I'm a researcher with Wondros, and Wondros is a creative agency that works to develop creative campaigns that inspire social change. And so for these breakout rooms, I'll be your facilitator. Just for some quick ground rules, I'm going to introduce our presenters shortly, pass the mic over to them. In the interest of time, for our other participants, if you're comfortable too, feel free to introduce yourselves in the room chat. And then when we move on to our discussion portion after these presentations, if folks want to speak up, I'll ask you just to share your name and your role as we engage in that conversation. And just as a brief reminder, we'll be discussing strategies to address discomfort and reduce barriers to vaccinations here in this room. And we're just looking forward to engaging in this discussion with you all. So with that, I'll get started. First, I just wanted to hand it over to Lourdes Basconde Garbanati, if she wants to start us off.
Great, thank you very much. So what I wanted to talk to you about today is some of the strategies that we've been using in our Stay Connected Los Angeles. Some of the data that you saw earlier was presented by Kayla De La Haye, who is my co-principal investigator on this program. So we've been using different strategies to increase vaccinations through our Stay Connected Los Angeles. And among those have been the direct contact with several community-based organizations like churches, where we've contacted 96 churches one-on-one, 79 senior centers, 15 schools, and 89 community organizations, with also a series of follow-up calls for anyone who didn't show. And Rosa, who's here in the group, has been in part responsible for making that happen. We've also been working with the Neighborhood Academic Initiative, which is a program at USC that brings a variety of middle schools and high schools together to address some of the different kinds of disparities issues, as well as to help them and support them so they can apply to colleges. So there's 900 students that are part of that program, and those are the students that we're really focusing on now. And Richard, that was the part of my email to try to see how we can get those kids now vaccinated. So we're shifting our focus a little bit to get to that younger population. Next. So one of the things that we've done, and this has been a collaboration, not just with the Stay Connected Los Angeles, but also with this program that is hosting the symposium today, Vaccinate LA. And part of that has been to train a series of promotores de salud, or community health workers, as community vaccine navigators. Once they go through this training, which is taking place over a 4-day period on Zoom, some are 2-hour sessions, others are 6 hours, they'll be trained on the basics of COVID-19. The trainings are all in Spanish as well for these different groups, and also on coronavirus. And we have added modules to an existing training that was part of the CTSI on mental health research and on logistics of navigation, because access issues have been one of the primary issues that we have faced in the community. And so the CVNs are able to navigate people through this. Also, we have an 8 weeks program where some of the CVNs or community health workers will be engaged in weekly sessions with for about 8 weeks with 60 individuals who are at high risk in the community, so that we could really understand what are some of the particular issues of those at highest risk and more hesitant to get the vaccine. Next. One of the things that has been just tremendous for us has been precisely the ability to get shots in the arm through these various sources. So this was an effort at Keck Medicine where during one weekend we were able to bring over 300 seniors over, but it took quite a bit because it really included even the transportation issues that we had to deal with. It wasn't only the vaccination itself, but even getting people to know that they had an appointment was also really challenging, because some people have phones that are pay as you go. And so in those kinds of situations, we couldn't really send them a message because they wouldn't always accept it. And so we needed to make direct phone calls to landlines in order for them to really understand. And this is one of our seniors, and really what she said to us was that you're giving me a chance to live. Me está dando una oportunidad de vivir. And so that's really reflective of how appreciative many of these people were, because they would not have otherwise done it. So now we're trying to work with Richard and Keck Medicine, and we've been approached by Curative to see how we can get more mobile vans into our network of community organizations. Next. And we're working as well with 11 community artists as part of the Stay Connected program, which are developing projects that range anywhere from the written word all the way to theater, space, place, projects to murals, posters, lampposts, and social media. And this is one of the projects that we're working on. And what we've done is that throughout all of our projects, we've connected our investigators, and Jane and Kayla are here, who are the lead, part of the lead investigators on this program, with some of the community artists in the Boyle Heights and East LA community. So it's been a partnership between academic and the community in order to develop the messaging, in order to develop programs that are going to really reach various communities. And so this is just one of those projects, but we also have theater, we have folks that are doing write-ups, we have murals, and a variety of social media approaches as well. And finally, just to end, I want to show you what is the main sort of images that are going to be used in this campaign, which will be launched in May. Can I have the next slide, please? I'm sorry, the next one after that. There you go. And so this is our final imagery for the campaign. It's right now, it's going through approvals, both at Keck Medicine and at the Keck School of Medicine, as well as at Central, at the UPC campus, because it has the university logo on it. But this was created by the artist in the community. His name is Paul Botello, and we've worked with him now for several months on perfecting the message, perfecting the images, and really trying to get out into the community. So these will be for the Latino community of the Boyle Heights area and Lincoln Heights and El Sereno. They were done in part with the community. The artists also have received feedback from town hall meetings, as well as community advisory committee meetings, where they have also embedded whatever was needed to make the changes. The second one is a mural within a mural. And the first one is more of a longer mural that could go on lampposts, could go on bus benches, and there will also have blankets, as well as grocery bags that will be utilized. Some of the posters will be placed in community organizations. And at the end, the culmination of all the work from all the artists will be shown in a digital arts festival that will be happening at the end of August or early September. So those are the creative ways that we're trying to find to really connect with the community and get folks vaccinated, and then pay special attention to those that are in particular need through the patient community navigators, who will really address some of the issues. Some of our communities have cancer or have other conditions that make them much more vulnerable. And we want to make sure that the needs are addressed, because as the first speaker said from the Ad Council, some of them are immunocompromised and are terrified, either about the disease or even about getting the vaccine. And so we want to make sure that those folks, we understand that. Another issue that has been raised by one of our investigators is the mental health dire needs in the community. Mental health has been such an incredible issue. Part of the module in the training of the promotoras goes into dealing with mental health as well. And I think this pandemic has gotten the best of a lot of us, but in addition to that, some communities are suffering more because of unemployment and already many social conditions. So with that, I'll turn it on to Claire.
The next presentation we have, which will be, okay, sorry. Do you guys have any questions for Lourdes while I'm pulling this up?
Let me know if you have any questions, or you could put them in the chat and we'll look at them as well. Well, Claire's getting the other set. I just want to thank Jane Steinberg and Kayla Delhague and Rosa Barahona, who are here from the Stay Connected Project, who've been putting countless hours into this program. So thank you guys. And you can ask them all the tough questions.
Working with artists has been the funnest project I've had for sure during the pandemic.
Yeah.
Okay, I think these are Jennifer's.
Yeah, that's
You're
fine.
ready? Okay, great.
Okay. Hi, everyone. I'm Jennifer Unger. I'm on the faculty in preventive medicine at USC and work closely with Lourdes and Kayla and Jane and a lot of the other people who are here. So hi, everybody. And today I'm going to update you on the USC Trojan Pandemic Response Initiative, otherwise known as TPRE. This is an ambitious study started by Howard Hu, our new department chair, to understand COVID and the vaccination response among the USC campus. So if I can have the next slide. So we're trying to survey, we have a very ambitious goal, probably overly ambitious, to survey all USC students and staff. And there are 28,000 students at USC. Wait. Oh, wait, what? Okay, thanks. So there are 28,000 students altogether, and we've been sending them email blasts directly to their email addresses once a week since April 5th, and we've gotten over 4,000 now. It's still a small percentage, it's only 15%, but that we've heard that that's actually good for like email blast surveys of USC students, and we're still trying to lure people with incentives. The sample that we have is pretty similar to the USC population. A lot of Asians and whites, some Latinx people. We're having a hard time recruiting African Americans, so we might have to go through some student organizations and try to get African Americans a little more engaged. We have slightly more females than males, but that's typical of surveys. Can I have the next slide, please? So 79% of them said they have not had COVID. Only 14% said they have had COVID and 7% don't know. The group that's most likely to say they had COVID was other, followed by Hispanics and whites. And it's hard to tell in this age group because there are probably people who had COVID but didn't even know it, and people who just who didn't have COVID but thought they had it. You know, they had a bad cold but they didn't get tested, especially in the beginning of the pandemic. But this is how it's looking from self-reports. And we're also trying to get their test records and also getting blood samples from some of them to look at their antibodies. And the next slide. Their vaccine status and hesitancy. 46% of them are fully vaccinated, which is pretty good considering that a lot of them have only been eligible to be vaccinated for like a month or two. There's a big chunk who are partially vaccinated, so we need to get them to finish up their vaccination process. And out of the people who haven't been vaccinated, most of them say they plan to get it ASAP. So I'm not sure what's going on with these people. Maybe they just need a slight nudge. Maybe it's just not convenient for them. You know, maybe they're procrastinators, but most of the people seem to be willing to get it. There are 4% who are saying probably, but they're going to wait. 2% haven't decided, and there's only 1% that said they absolutely won't. So it seems like the students are pretty open to it, but there are some people who are procrastinators. Can I have the next slide? And we also see some racial ethnic differences. There are more hesitant people among African Americans and Middle Eastern students, and the least hesitancy among Asians. So so we can see that there are some groups that we need to target with better messages. And next slide, please. Whoops, wait. So we're very much at the beginning of the study. We've just done one short survey just to recruit people. Then we're gonna, from that survey, we're gonna recruit people into a much more extensive survey where we'll get much more into knowledge, attitudes, beliefs, stuff like that. And we're also recruiting about 600 people into a biomarker survey where we're, among people who have been vaccinated, we want to see how long the immunity lasts before it starts to wane and they need a booster. So that's all underway. We still need to reach out to underrepresented groups. We hope to use this information to inform the USC community so that they can do better outreach to people who are hesitant again about getting vaccinated. And we hope to develop some interventions for the hesitant students. We also plan to survey the staff. We're lagging a little bit behind on staff because we haven't been able to get an email list of the staff. So if anyone happens to have an email list of all the USC staff laying around, please let me know. Otherwise, we're going to hack into the student directory and get it ourselves. But so that's a quick snapshot of our student survey, and I'm happy to answer questions.
Dr. Unger, I have a question about comparative data. Have you had the chance to compare this with other universities in other parts of the country? I'm just wondering if the very low rate of hesitancy is common among all undergrad students, or it's just unique to LA.
It could be unique to LA. We're not sure yet. We've just barely started this, so we haven't really reached out to other universities. And unfortunately, there doesn't seem to be like a standard survey that universities are giving out. So everyone's probably asking the questions slightly differently. And so, yeah, the answer is I'm not sure. And Tom just put in the chat, any sense of selection bias here? Yes, that's a definite concern, that we're getting all the people who are interested in COVID and interested in science, interested in surveys, willing to give out their information. So we're missing the people who don't trust science and don't trust researchers. Those people are not talking to us. So we're still trying to reach out to them. And Christian said, how are students being recruited? We're emailing them. We're sending out like a big mail merge of emails. So you'll get a thing that says, Dear Lourdes, as a student of USC, we're very interested in your opinions about COVID. Please click here to fill out the survey. Then they click on a link and they come to a little video that explains the survey. Then they click on another link and it takes them to the online consent form, which they have to click on and sign, and then it takes them to the survey, and then they get a $20 Amazon gift card. So yes, are you targeting certain, oops, I lost the chat. Are you targeting certain groups or organizations? Yes, we plan to. We started out just going by email, but now we're gonna start reaching out to student groups. So yeah, and it's definitely a concern that the people who are hesitant are probably the people who are hiding from our survey. So we really need to find them and understand them better.
Great, thank you so much. And any other questions? I encourage you guys to answer in the chat.
Mariana said, will you only target students or older people too? We want to survey all of the staff. And although this is an initiative from the provost, some bureaucrats below the provost have not allowed us to have a list of the staff's emails. So we're looking for ways around that right now. They allowed us to advertise in a little weekly newsletter called Gateway Connect, and we got a few hundred people, but it's a really small sample, I think. And each USC school should have a staff listserv. Yes, they allowed us to contact the people who are in charge, or they allowed us to contact the person in charge of the people who own the listservs and recommend that they might want to recommend this, but we're not allowed to push it. So what ended up happening is a tiny little message to the Trojan Council saying like, we've been asked to promote this dumb thing. And it wasn't very optimistic. So I don't think that worked too well. We need champions who are really in touch with the staff. So we're really hoping to get their individual emails, and we are pursuing sneaky ways of getting that.
Thank you so much, Dr. Unger. I was just hoping, because we're on a tight schedule right now, but please, I encourage you guys to ask questions in the chat, and I hope you can respond in the chat as well.
Sure.
And I wanted to move on to Ashleisha.
Yes, hi. Can you hear me clearly?
Yes.
Okay, great. Thank you. I'm Ashleisha Datar. I'm the Director of Program for Children and Families at the Center for Economic and Social Research, which is in Dornsife. And I am going to share with you some things that we've learned from some work we've been doing in the WATS community over the past several years. You know, and as Kayla's presentation mentioned, that WATS happens to be one of the communities that has some of the lowest vaccination rates. So even though in this particular study that I'm going to describe, we don't really get into things about vaccine status or vaccine hesitancy directly, but I'm hoping that with some of the findings I share here, it provides some useful context for the discussion that we'll have later. Next slide. Okay, so just to give you an idea, we were this was a natural experiment study that was, you know, the goal was to assess the impacts of a major public housing redevelopment on residents' obesity and related behaviors. It's a study funded by NCI and NICHD. So we began in 2018 and recruited a longitudinal cohort of over 800 adults and 700 children from 3 public housing sites in Watts, Jordan Downs, as well as 2 other control sites. The vast majority of our adult sample has been women, because typically in public housing projects, it tends to be more single moms who live there, with an average age of about, in their early 40s, about 62% were Hispanic and 36% Black. So this is a very predominantly minority, very low income community, with 80% of households having less than $20,000 of annual household income. So we've done 3 waves of data collection since 2018 on this cohort, and the 4th wave is going into the field in this June. So unfortunately, when we rolled out our surveys last year, we were at the very early stages of the pandemic, so we didn't really get into questions about vaccine or vaccine hesitancy or anything like that. But we did put together a module about what challenges families faced because of the coronavirus restrictions. And so I just wanted to share some findings we have from that line of questioning, because it provides some useful context for our discussions today. So that's what I'm going to be talking about. Next slide. So this was one of the questions we asked in our survey, which said, how much of a problem were the following on a scale of 1 to 10, where 10 was a very big problem and 1 was not a problem at all due to the coronavirus restrictions. And we gave them all these different options. These were not necessarily in this order, but I've ranked them in terms of what were the biggest concerns versus what were the least biggest concerns. And interestingly, education was the top concern. But what was surprising to us was the food security and access to food were least problematic. And I think that speaks to, this was a little bit contrary to what Kayla indicated before in her presentation, that food security was a big concern among low-income minority families, but perhaps this suggests that the safety net is working great. The food banks and food pantries were out there providing access to people, for access to food, etc. And so they consistently rated that to be, towards the lower end of a concern during the coronavirus restrictions. But along that continuum, things such as experiences with social connectivity and jobs and income, I thought there was a lot of heterogeneity there. So I think this is what I feel like maybe provides some context for thinking about, these are concerns people had. Education was a top concern among people in these low-income minority communities. And people had different experiences with social connectivity. Some people didn't have any problems with meeting their friends and families, and other people thought that was a very big concern for them. Similarly with jobs. And I think jobs, again, the heterogeneity was because a lot of people, a lot of women who live in these public housing communities are not working. And so they were in some ways protected from any kind of income or job shocks, whereas other people, so I would say probably 70% of the sample was not working, 30% was. And so the people who reported high concerns with job loss or income were probably on the working individuals. So anyway, we had, I just wanted to put this out there to tell you this is what we found, and hopefully it will help with thinking about strategies to meet people where their concerns are. And hopefully that will spur some important discussions. And I stuck with my 3-slide quota that was given to me. So I'm going to leave it at that. Thank you.
Perfect.
Thank you so much.
Oh, go ahead, Claire.
Oh yeah, no, I was just going to say thank you, and I was going to kick it off to you to facilitate. And I think if there's any questions too about that presentation, also the chat would be a great area to do that, so we can move on to the prompts.
Awesome. Perfect. Well, thank you again to our presenters. Really appreciate your insights and your time. So for this next piece that we have about 23 minutes. We have these shared discussion questions, and I'm going to drop these in the chat for everyone now. And so in this time together, we really want to kind of open up the floor and walk through these questions together. Just some tips. We have these 4 questions, but in case anyone is eager to hop in, if there are multiple folks speaking at once, feel free to write stack in the chat, and we'll be looking for that. So we can kind of call folks in order if there's a certain popular question. And yeah, with that said, for this first question, we can dive right in. So number 1 being, what are the top 3 issues that need to be addressed to encourage vaccination?
Is this just like throw your ideas out there sort of session?
Yeah.
Okay.
Yeah. Just an open discussion, open conversation.
Well, I could start and just say I was really, Ashleisha, that data that you shared about like ranking people's concerns was super helpful to see. And I think it aligns a bit with, there's a big group of folks that we have talked to and that we see in the data that are not particularly hesitant, but what Lourdes was referring to is like, it's just too hard. And just all of the concerns that you listed and how many there were that just seem overwhelming in terms of childcare and managing all of those things. Addressing those as kids go back to school. I mean, a lot of them aren't easily addressable really. And so how, just if it's a little bit hard to get a vaccine in the context of what you just presented as all these things going on, it's understandable that it's a tough thing to book and do and make time for in that context.
Right, and anecdotally, I will say though, one thing that in this particular community, violent crime is a big concern, especially now over the past few months. We've all seen the statistics on that there oftentimes you hear from people that, there are worse things going on in my community with social issues. And is coronavirus the top concern for me? Maybe not, right? So I think that's something to think about is, when they have bigger problems to think about, maybe they are underestimating the risk, or I don't even know if they're underestimating the risk, because crime is such a big thing that youth are affected by that very significantly. Maybe though that, again, you were talking about the risk benefit calculation. That calculation is very different there.
Yeah, I would agree with that. I think, or my experience has been, it's the, Alicia, it's the survival of, in addition to the crime, just the not quality of life, but living as a priority, and that falls into the mental health. But one of the things that I wanted to ask, and I thought on one of the questions, I think it was an add-on, is the access to care. Does the community have a relationship with a healthcare system or a healthcare provider, like an FQHC or even a community pharmacy that would lead a dialogue or conversation to vaccination questions and concerns?
I could address that. Not always, Regina. Some of the community groups are very, very poor, and they're also afraid of being seen as a public charge. And that even came out from our town halls and focus group meetings. And so what happens is that many of the community-based organizations in the area or the churches are the ones that really connect them to some of the services. What they do rely on a lot are pharmacies, and that's where Dr. Dang's group might be really influential, because sometimes the pharmacy is the first line of defense in terms of healthcare.
Yeah, I've seen many pharmacists referred to as doc in the African American community, because that is their face of healthcare in the community.
Yeah, I just wanted to add, I agree with what you both said, and we did a survey where we asked people if their access has changed over the course of the pandemic, and we found that for Black and Latinx and Asian folks, they were not able to see their doctors when they needed to. They were much more likely to report that in our surveys. So, I mean, it was bad to begin with, and it's probably gotten worse during the pandemic. And we really need to figure out how to repair those relationships, because, you know, clinics are still a trusted source of information, but if people are having difficulty getting seen, then, you know, that's a whole nother level of barriers we need to fix.
Gina, could I ask you, or maybe anybody else who knows? I'm Tom Buchanan, I'm Vice Dean for Research, so I'm just kind of a fly on the wall here, but I was wondering whether it's too nuanced to talk about all of the chronic complications we're seeing from COVID, even if it's mild, because I think there's this perception that you get COVID and if it's pretty mild, you're okay. If you're older or have some other disease, you might get sick and die from it or something like that. Is that like too far down the radar screen to worry about at this point in time, or is it an important point to make?
Well, you know, I would say, I'm not sure of this, if someone has symptoms, how would they know or even be diagnosed with COVID if they've got the fear of the virus anyway? It's either, you know, I'll get tested, or I don't want to know, or I just have quote unquote the flu. So I think that's a concern as well, you know, and, you know, correct me if I'm wrong, we're tracking more vaccinations versus, and it used to be cases and it's kind of flipped now. So, you know, it may be even that people aren't even going for testing anymore because they may think it's not available nor a priority, or I can get tested, but I got to get vaccinated, or, you know, the focus on vaccination now. So just throwing that out there, Tom, I don't know.
Yeah, I think, you know, what I was thinking about is trying, you know, you're getting down to this group of people is resistant. We've seen all the reasons, but it's always, well, I think many times it's a balance between, you know, what if this could be bad or this could be good. And, you know, COVID's not that big a deal for somebody my age, just like getting the flu. So I'm just I don't want to take these risks. And I think people don't understand that even individuals who had a mild case of COVID, so like you say, they don't know if they got the flu or not, but it's still out there. And if you get a mild case, it doesn't mean you're going to be okay. We're seeing lots of people are ending up with chronic fatigue and not thinking very clearly. I would think like young athletes, you know, damaging their lungs and things like that. So I'm like, you know, there's so many other important things like survival in the community and some of the other sort of day-to-day survival things that people have out there. And maybe this is too nuanced, but I think it's one of the things that I've heard that even, you know, my friends' kids don't really understand, that they could get a mild case of COVID and it's not over like it would be with the flu or a cold. It could be something that's going to affect them for a long time.
Yeah, even they're just, go ahead, Sheila, I'm sorry.
Thank you. I actually think the comparison is wrong, that people are comparing. It's like my current status as being okay, the status quo, versus something potentially negative side effects I'll get from the vaccine potentially. They're not thinking that shouldn't be the comparison we're pushing. The comparison they need to take into account, to follow Tom's point, is COVID and long-term effects from getting the virus, right? As opposed to the current status quo. The status quo, people I think in their mind are thinking the status quo against possible side effects of the vaccine. And I think we'll have to be clever to think about how to make that point, right?
But I'd also say who delivers the message, right?
Yeah.
Who delivers the message? There's a lot of this information that they get from social media or from their my aunt said this and so said this and this happened to my neighbor, and that's really how they're getting a lot of their information. And I don't know, Kayla, do you know anything I know UAS collected information on what was the source of information. Can you see what that looks like by race, ethnicity to see?
Yeah, they've been asking about like various government and media sources more, not so much about there hasn't been a long track record of asking about like doctors versus pharmacists and stuff, but there has been pretty high trust in local government officials, like the mayor's office, and that's been high in the Latino population. But I think they're just starting to ask now about more medical providers in the context of like, who do you trust about your children's getting like a child's vaccine? So that might come out now.
I want to follow up on Tom's comment, because I think I have encountered that line of discussion with different people that were hesitant at different levels of the community. And I think this idea that I'm okay, I'm taking care of myself, so why should I risk my health with a vaccine when, you know, I'm healthy and chances are that if I get the infection, it won't be too bad. And I think underneath, when I ask those people, why are you hesitant? Why not get it? Underneath is mistrust about long-term effects. And many people have told me, well, we know the short-term effects are okay because it has been published or because, you know, it has been reported, but we still don't know the long-term effects. And that's kind of a conversation stopper, because it's true, we don't have data. But if we think about the biology, we know that the chances are that there will not be long-term effects, because what we're doing is triggering our immune system in the same way that the infection would. So what I try to tell them is, well, if you get the infection, your immune system will protect you for future infections. That's what the vaccine is doing. Nothing is remaining in your body that is not supposed to be there. You're just creating immunity. And a lot of times when people understand that, they're like, oh, okay. But I'm seeing a lot of that, particularly now, and I was just sharing in the chat box with Jennifer, I'm seeing a lot of hesitation among parents of 12 to 15-year-olds. Now that the vaccine is approved, I've heard conversations at my kids' school, weird, crazy, you know, things saying like, I'm not gonna give the vaccine, you know, I'm gonna get my kid out of school if you force me to do it, because, and their argument always goes to the long-term effects. The current data doesn't have long-term effects. How do we know that this is not gonna harm my kid? And I think that there is where we can do some education about, this is what's likely gonna happen long-term, right? Because a lot of people don't understand. They think that they're getting something in their cells that is staying there forever. You know, they don't understand the biology of the vaccine. And I think if they understood that, the fear of the long-term effects would dissipate.
Have there been any questions from the community? And I think about gig workers and workers who are, say, for instance, working in a restaurant, a waitress, line cook, or someone, you know, cleaning tables, about balancing the decision of getting a vaccine and the concern about, oh, I won't be able to work because I may have side effects, versus I'm concerned that getting a vaccine and cutting my work hours, I won't be able to pay the rent. And, you know, there may be people out there who aren't supported by the administration's program to pay people to, well, you know, they're saying that, oh, you know, we're going to force people to go back to work, or they've got the new requirements in the I forgot the name of the program from the administration to sort the unemployment. So has there been any questions about that concern in the community about, you know, balancing work versus being balancing work and keeping food on the table and paying the rent versus time off to get a vaccine?
Absolutely, we've seen it, and one of the things is that you know, some employers are being encouraged to give time off for getting the vaccine, but I don't know in implementing it how well that's been happening. But absolutely, we're seeing that. You're right on that. And I just wanted to also mention that, related to Mariana's comment, one comment that we're still getting, which is just, you know, mind-boggling to me, is the fertility issue, especially in Hispanic families, and how that could be impacting their little daughters. If they vaccinate them, are they potentially rendering them infertile for the rest of their lives? And so, you know, how do you respond to that? Because we really don't have the research to stay, so we provide everything that we have. But I think that the key is to really address the concerns and try to understand where they're coming from, because I think some of the concerns are quite legitimate, given, some of the questions that still are out there. I mean, we're all gung-ho about the vaccines, but these are not medically inclined people overall to begin with. And now we're trying to, make them move in certain directions.
Just for a brief moment, it sounds like based on the responses that we've kind of talked a little bit about sort of what could be leveraged, so question 2. So I kind of want to prompt us into number 3 in terms of what recommendations might there be just for different population segments.
If I could just pick up on Regina's previous comment, I actually was hearing from a family member that her employer was paying everybody $50 to get vaccinated in that workplace. Nice. And that was a important incentive. A lot of people took advantage of it. So that was interesting.
Incentives do work.
That lottery in Idaho, they saw a huge spike in uptake after that.
Mm-hmm. Yeah, now they're having a lottery for Lakers tickets, I think, in LA.
Not quite $1 million, but pretty good.
You can get.
New York is giving out free cannabis joints for jabs.
That's great. That's funny.
For young people, I guess.
That's very creative.
Yeah.
Well, what about us early adapters or believers?
Really. Go back and get
like
your free joint.
Yeah, I don't need a joint, but I'll do the million.
Qualify if you have a vaccine card, vaccination.
I'm sure it wouldn't be easy because I'm sure it's all bound with, legislation, but you've got the California lottery. I mean, why couldn't they sort of peel off some part of that and use that to incentivize folks who've been at, a lottery for those who are getting vaccinated?
I'll take a credit on my real estate taxes.
I wanted to add one thing. Yesterday, I was actually talking to a friend of mine who is the holding out person in our friend group, not getting the vaccine. Yes, I know. We're not going to talk about that. But anyway, I told her, what are you waiting for? Also, what do you want? She said, I want incentives. And she's like, interestingly, I signed up for this concert in the park, and there was a higher price ticket there was an unvaccinated section, and you have to pay twice as much for a ticket if you're not vaccinated. So this is some park pop-up, I can get the name, but it was some kind of park, something happening in the park in downtown Grand Park. So she was like, if I have to pay more or sit in some other section, it's going to be really embarrassing. So, kind of like we've seen in public health, people don't respond to messages about, smoking is bad. They respond to messages about vanity, or that, sunscreen, they're not going to apply sunscreen because they want to. They're going to do it because they're afraid of fine lines or something. So it kind of reminds me of that a little bit, kind of classic public health stuff, that basically people are motivated by, I want to say sort of silly things, not, in my mind, not logical things like, hey, you might die. They're like, oh, if I have to pay more and sit in another section, that might convince me, right?
Yeah, well, that's exactly what worked for smoking. Smokers have to go outside and they can't hang out in the bar and restaurant with their friends. That helped a lot of people to quit.
Especially in cold weather.
Yeah.
You have to stand outside, lean against the building.
But I think that begins to show you what sort of messaging, and by the time you get down to the people who are saying no, it's a different sort of messaging. Then here's why you should do it from the scientific standpoint, from the health standpoint. That tells me that this just isn't high on the radar screen. COVID's over there somewhere. They're thinking about ball games and concerts and other sorts of things. So it does. You guys know more about the messaging than I do, but it suggests that the messaging does need, and the incentives need to be at a different level than they were for the first half of the population.
I shared this with Lourdes, and not to derail, but men who have been infected with COVID are 6 times more likely to have erectile dysfunction.
I feel that like that ties into what Tom was saying, that the late night host had a field day with that last week when they're like, why has the CDC been telling us to just to like mask up? Why didn't they tell us this 6 months ago? Because I would have gone and gotten vaccinated.
Yeah. And that's another thing that worked with smoking, with those billboards with the guy holding the limp cigarette.
Marlboro Man.
There,
having
yeah.
Problems.
Yeah, there you go. That's
So
all you
did the
need to
horse.
say. Yeah.
Let's use it.
That's right.
Let's use it.
Joe DiMaggio and maybe some of those old jocks.
Yeah.
Do a vaccine campaign. I'd love it.
Yeah.
Well, I have a question.
Oh, go ahead.
Sorry. I have a question for Guy and Diego, the Wondros guys. The conversation we just had brings me to a point that is apparently oddly contentious, which is that, and Catherine mentioned this at the beginning, which is that you should never do these negative messages, right? All the messages you should do should have a positive tone. You shouldn't try to scare people into all of this. And I'm a little surprised by that, given all the evidence we have of what works to get people to quit smoking, what works for cessation. And I've talked to, all the people the people have cited for having research to not do these negative messages. And when you sort of get them in a room and press them on it, they all sort of say, yeah, we don't actually have any of that. And one of the groups that was sort of leading the don't do the negative message charge told me that they're now thinking of switching over to now starting doing these sort of, negative is the wrong term, but sort of scare messages, right? So the erectile dysfunction thing is a perfect example of this sort of thing, right? Is that people, I forgot who said it. Someone earlier said everyone's at sort of the status quo, right? They're not sort of evaluating the risks, right? And so if you sort of get them to focus on the risks, since we're so bad at doing this sort of, right? So I was wondering, is that something that's sort of being thought of outside of the ad council, which is still saying we have to all be happy and sunny still?
I think, just to jump in here, I think there's a lot of validity to what she was saying about the ad council research, and which we've also seen. We do a lot of one-on-one interviews with people and get their points of view. And so what I heard was very validating. But there's also a lot of research that shows that different people may require different types of messaging. And so there's an argument also for a both and or all of the above type of approach, where you do have different types of tactics in your messaging to appeal to different communication needs or different emotional needs in people, because people will have different emotional triggers, if you will, that will inspire them to get the vaccine. So like for some people, it might be something that scares them, like, oh, you know what? I didn't think of that before. That scares me. I better consider this. But for other folks, again, going back to the ad council data, it's like, if you do that, that will really turn them off and say, oh, you know what? I don't like being manipulated with fear. And I know that's what you're trying to do. But there's some research that shows that kind of thing does work for some people. It's kind of a chicken and egg. It's hard to determine like who is working for it and who is not. I mean, if we track our messaging and see what the performance is like, we can get a better idea of that. But
it would be
all of the above also seems to be an approach to consider.
The psychology literature in advertising and health communication clearly, this is a long studied thing about the level of fear that works. You need at least a moderate level of fear to get people's attention. A moderate level of fear with a very clearly articulated way to avoid the negative consequences turns out to be the key. And that might be the key for men, particularly maybe conservative men, sort of, if you could get them to focus on, their diminished sexual performance, perhaps, might be enough to sort of put them, and again, it might be all of the above. I think different people are going to have different hooks, right? So some people are going to want the, kind of more positive, upbeat thing, but there will be some people who won't do it unless it's, who don't, really won't do it unless it's in their own vested interest and there's something really in it for them, whether it's an incentive or going to a concert they want to go to or worrying about erectile dysfunction. I literally, so.
Speaking of conservative men, I don't know if anyone heard was it a This American Life episode where they had a focus group with Trump supporters, And the conclusion, one of the conclusions they came to is that a lot of folks in that group wanted to hear it from their healthcare providers that they needed to take the vaccine. But if you actually, what I'm hearing from healthcare providers is that they're not really talking to their patients about it, and they're not getting information about how to do that. And for example, at CAC, providers don't even have a handout to give the patients about the vaccine. So, I think at least that's what I've heard.
Yeah, that's an easy fix.
Yeah, that's an easy way. We can do something about that one. So I think some emails are going around about that. So anyways, there's some really simple places where we can start, but I think we should do that low-hanging fruit, right?
Well, and
this
that
is
was
a card for providers. Give to your patient.
Weren't we part of the development from the UCI group that was provider initiated just for a handout? It was provider directed, I mean. Allison, you remember that, or Michelle?
Yes,
there was several, okay, you have it now.
Yeah, but that's then, partnering with Altamed and Watts Health and, a number of the other providers, and really reinforcing the message that they, delivering that sort of message in the context of care is super important, and maybe jointly developing an FAQ or a handout with them.
I think I want to stress what Sally is saying. This has been something that I've been struggling a little with, in that there's also, just have to focus on the positive messaging. There's also been all this stress on access, and clearly access is important, but we're talking with provider runs a clinic down in the east part of LA, right? So it's a pretty big clinic. They have a ton of people come in, almost all low-income Hispanics. And he asked them, the first thing they do when they check in is, have you been vaccinated for COVID-19? And then if not, they say, would you like to? We have vaccines right here, So it's clearly not access. He says, basically everyone says no. They have very low take-up. So there's some barrier there that's not, at least amongst this population, that's not about access. You can't make it any easier than you happen to be at the hospital, the doctor's office anyway. Can we give you a shot? And people are still saying no. So it could be something about, they don't do anything resembling a hard sell. He says they're very sort of soft sell about promoting the vaccine. So it could be something like getting the providers involved. I don't know. I don't know what it is. It could be that, it is this sort of misinformation that you guys were talking about. So people are indeed concerned about things like long-term side effects. They are concerned about, I may get, flu-like symptoms and miss work. They are concerned about, I don't know what it is. I think it can't be just, I don't know. It clearly can't just be access to care. It clearly can't just be these positive messages about, oh, this will be great, protect others. Oh, you'll feel good about this, right? Because it's not working by itself. And I don't know. I kind of want to hear more about what the seizure people have to say, given the really cool data you guys have, right? It's the long panel, right, Kayla, where you can sort of see what, I think you should be able to see what people have answered to all the sort of Caesar questions in the back. So you know who they voted for, where their sources of information are. Just, you need to merge all that data, and then we can sort of.
It's merged. So there's potential. Okay. I mean, it's just, if you have the time and interest, that data is there where they know their history for years back, medical history, voting preferences. That's all there. So you can really dive into that data from a bunch of different angles.
I will caution, though, that that's a very internet savvy group.
Yes.
These are very different from the people we've been talking to in Watts, who would not participate in a study like that. So, they're just different groups, and I think you have to meet them where they are.
I thought the survey, you guys know more. I thought it was trying to be nationally representative. Is it not?
The UAS is, but again, if you're talking about low-income minority folks, yes, they sent them a device so that they could be online and participate in this panel, but yes, it's nationally representative, but is it representative of low-income minority people? No.
Yeah, there's demographics there, and I think that you don't get the depth of a lot of those things too. Like they are really brief questions and survey responses, so you wouldn't get the insights that you would get from like going to have a focus group somewhere.
I mean, I just, based on my experience with folks in the Watts community, it sounds like if regular people were to get on their social media or TV or some sort of advertising campaign where they say, oh, look, I went and got my vaccine and this is how I felt about it, or this is how I thought about that decision. You know, it's like they don't want to hear it from people, because otherwise it sounds like someone is breathing down their throat and telling them that this is how you should be thinking about it. But if it's another person like them who is getting on TV and saying, oh, this looks like my tia, or, you know, she's, yeah, you know, she had these concerns, but then eventually she took the vaccine because she felt for her this benefit outweighed that cost, you know, and for every person it could be different. So maybe something that people can relate to, I think would be more powerful in that particular community. Again, I've no base, I'm not tested this out, but it's just just an idea.
Can I ask, are there any thoughts in terms of recommendations in terms of different segments of the population, in terms of, you know, Latinx, African American, or even just adolescents, the youth in LA?
This is a comment that's not specific to any particular targeted group, but I will say from the work that, you know, we ran some groups with LGBTQ service providers, and so those were members of the community, and they were really clear that you just really can't be talking about and offering vaccines without acknowledging all of the other need. And so, you know, really thinking about at vaccination sites, you know, having food there potentially, access to other resources, just, really wrapping a bunch of needs and services around that vaccination, because the needs in so many communities are just far greater than needing to be vaccinated.
Michelle, can you explain that a little more? I didn't quite understand. So
it's just, you've got people who are food insecure, they got residential instability, they've got all sorts of, concerns that might involve legal, they've got mental health needs, they probably don't have a healthcare provider in many cases. And so really thinking about, at a vaccination site, creating access to some of those things, and maybe handing a bag of food while they're at it, right? So
for some of those stuff, wouldn't the financial incentives take care of it? Instead of giving them a bag of food, here's, $50 to buy food? Or I guess I'm wondering how you would sort of implement something like that.
Yeah, it could be, at a vaccination site, you just bring a whole bunch of other care providers.
And so you advertise it as it's a general care thing plus vaccination, or?
Could be a health fair type of thing.
Mm-hmm.
So just like a general health fair, and at the health fair you offer vaccinations, that sort of thing?
That could work. We're even looking into malls, seeing if people they go to malls, so we may go to a mall and offer it there, or I really think we've got to offer beer.
That's the access thing again, right? That I was complaining about earlier, is that this focus on access, when we know that even granting access, there's still a lot of hesitancy and just turning down of vaccines, right? I think early on, this was definitely like a first order thing where like people just couldn't get to the vaccine sites and they're limited. And so, like the rich, safe at home people were able to, but I'm not sure that's the binding constraint anymore. And yet we still see like a focus on these efforts for access. I like Michelle's thing, because I think there's something there, but I don't know how to implement that. But I don't think access by itself is going to solve the problem, given, at least anecdotally, what we've seen in places where the access is there and yet people literally just turn it down, right?
I think it's also multifactorial, right? It may not be only access, but it may not be only all these other things. So you are going to have a multi-pronged approach. And as you said, at the clinic site, they didn't ask exactly why they were saying no. You just know that they said no. So was it those many things that you had mentioned, like they're concerned about side effects later to that day or the next day and didn't plan on it. So
welcome back, everyone. I had the opportunity to go to both groups and heard some really wonderful discussion. I think what we did want to do is to take a few minutes and hear as a larger group what were some of the comments that were made and any recommendations that came from the group. Before we get to that, though, I don't want to forget, there were so many people who were a part of supporting and developing and contributing to this research symposium, a whole team of individuals, Laura, Nikki, Swael, Claire, Allison, Christian, a whole group of people, and just want to make sure I acknowledge and thank you publicly for a lot of good work. So thank you. So at any rate, let's see what are some of the things that came up. Who would like to report first? Should we start with group one? I guess we could, it's easy.
Sure, yeah, thanks, Michelle. So, hi everyone, I'm Laura. If I didn't meet you in our breakout room, I'm the project manager working on Vaccinate LA for CTSI. So I'm gonna try to go through this quickly so we have time to discuss. I know there's a lot of information. So I'm quickly gonna summarize our presentations and then our discussion points. So first of all, we had a wonderful presentation on COVID-19 vaccine access in the LGBTQIA community. And some of the key takeaways from this are that the barriers to the vaccine are most harmful to trans people, LGBTQIA aging adults, and LGBTQIA people experiencing homelessness. And another key takeaway is that we really need to focus medical attention to better serve this community, especially this community of color, and that we need better LGBTQIA representation in developing our vaccine programs. So next up, we had a great presentation on the impact of the COVID-19 pandemic on childhood vaccine hesitancy. And a key takeaway from this presentation was that during the pandemic, overall childhood vaccine hesitancy and risk perception increased in the Latino and African American communities, and especially when it comes to childhood vaccine hesitancy. And next up, we had a really interesting presentation on detecting visual misinformation, specifically regarding deepfakes. So this is AI technology, if you're not familiar with it, that can misrepresent people and what they're saying and information online. So a key takeaway from this is that visual misinformation is really leading vaccine hesitancy, and we should really, everyone should be vetting any visual information that they see online. And next up, we had a presentation on vaccine misinformation and conspiracies on social media. And in this study, Dr. Liu found a large amount of misinformation on social media regarding the vaccine in general, specifically when it comes to scientific facts, side effects, effectiveness, deaths, vaccine refusal, and rollout. And so then we moved into our Q&A portion, and I'll try to quickly cover through what we talked about. So our top 3 issues that need to be addressed are, I kind of broke them into larger categories. So misinformation, like we talked about, specifically on social media. Structural distrust in general. We talked a lot about legal documentation, transgender community, the distrust that those communities have in the scientific, medical, and political structures. And thirdly, we talked about the importance of incentivizing the vaccine. So I'm just going to kind of move into our recommendations, which were things like not requesting a government ID and using trusted messengers, specifically faith leaders, DACA recipients, promotoras, local social media influencers, specifically local. We talked about that a lot, how it's important. Social media influencers are great, but as long as they look like the people or they're in the communities that they're talking to, that's really important. And this is great specifically to combat that social media misinformation. And another trusted messenger group is how important it is to empower pediatricians, primary care doctors, nurses, and providers who have, ongoing relationships with their patients when delivering vaccine information. And let's see. for our last section about communication in terms of our messaging for our campaign, we talked a lot about younger people and how to reach out to them, especially those who don't, see their healthcare providers often or regularly. So again, that comes back to a lot of combating that misinformation on social media, online, and emphasizing that the vaccine really affects not only them, but the larger community, and reminding them about the things they missed over the last year. Some examples I liked were a sweaty dance floor is something that we've all missed probably. So that's a way to get to young people. And another great example I wanted to share was in terms of combating misinformation. I think, Rachel, this was your idea, circulating memes that have, accurate information, scientific memes going viral. And that is a quick summary of our great discussion. So thank you all so much.
Great, super, thank you. So let's get a little report back from group 2.
Great, I'll report back from group 2, and I'm just gonna do this really quickly for the presentations. We had Lourdes gave a presentation a little bit on Stay Connected LA and the community vaccine navigators that are community health workers or promotores going out actually in the field and helping especially high risk individuals go and just get the shots in their arms, dealing with a lot of complex barriers with that. Also they're working with about 11 community artists to develop projects like from written word to theater to murals and social media to go out and do actually, art advertising in the community with posters placed in community orgs, bags, and really emphasizing, the benefits of getting vaccinated, also emphasizing mental health. We had also Jennifer Unger talked about a survey of USC students. I think there were about 14% who said they had COVID, 7% didn't know. The people most likely who to have COVID, I believe, identified their racial ethnic identity as other, followed by Hispanic and then white. And then 1% said they absolutely were not interested in getting a vaccine, and there are some racial ethnic differences. So African American and Middle Eastern respondents were more hesitant, while as you saw the least hesitancy among participants who identified as Asian. And they still wanted to reach out to underrepresented groups. Are they going to use the data to inform the USC community and do outreach and hopefully do interventions for the students? Ashlesha did a presentation on one of her projects assessing the impact of a housing redevelopment on residents' obesity and related behaviors. It was predominantly a low income and minority community, and they looked at the biggest challenges people felt due to the coronavirus restrictions. Education was a top concern for folks, followed by entertainment, eating out, and then childcare, and then keeping or doing their job, while food security and access to food was one of the least concerns. So as far as our conversation, I think we began this discussion that a lot of people for the vaccine, it's just not a priority for their communities. They have a lot of other things going on. People are just focused on their survival. People have concerns about crime in their community, and the vaccine is just not a priority for them. We also talked about the people's doctors being good messengers, as well as their pharmacies. Just people refer to their pharmacists as their docs in some communities. But we also talked about how people's access to their healthcare centers may have changed. And some people don't even have access to a health clinic in their community, but get those health services through CBOs or churches or other orgs. Also, we talked about how some people are just viewing coronavirus symptoms as mild, or the flu. So, if they're already healthy, they're just going to think, well, my symptoms are mild, so my symptoms will probably be mild. It's just like the flu, it'll just go away. So perhaps messaging just really needs to focus on, there's a lot we don't know, and there are long-term symptoms that need to be emphasized. Some people also have barriers with the vaccine, such as being afraid to take off work if they get sick. Some people might be worried about infertility issues, and all these concerns are quite legitimate and need to be addressed in any of the messaging that gets them out. I'm not sure if I mentioned this before, but we talked about trusted messengers as well. So having people's providers as the messages, like their PCPs or health centers that they go to. There's quite a discussion on incentives. So a lot of places now, there's a lottery for Lakers tickets if you're getting the vaccine. There's, I think, New York is giving out free cannabis, the Joints for Jobs program. And, some of the downside to this, people might be waiting to get a vaccine until there's those incentives, but maybe a scarcity approach might work, telling people, this sale is going to end tomorrow, so get your vaccine now. Also, we want to incentivizing employers to incentivize their employees, such as paying their employees to get vaccinated. In terms of like the tone of messaging, fear-based, we talked about, fear-based motivation and telling people about long-term side effects. It might not be as effective because we're looking at things like smoking or sunscreen. People are respond more to vanity or issues of like getting wrinkles. So we want to look at different ways, like maybe, getting COVID may cause erectile dysfunction. That will really pull people's emotional triggers. But yeah, again, a moderate fear-based approaches work for a lot of people. So it needs to definitely be tailored to the different community you're looking at. Is lots of people have different emotional triggers. Yeah, we talked about people don't like feeling like other people are breathing down their throat. People don't want to be told what to do, but they want to see people who are like them, or messages coming from messengers that they can relate to. In terms of seeing other people getting vaccinated and talking about their experiences with why they did it and how they felt after. And then there was some discussion of not just access, as I think Tom talked about, how they had people coming to their health clinic and they asked them at the front door if you've been vaccinated. Those who didn't, they said, okay, well, if we can get you an appointment right now, right here, if you want one. And a lot of people said no. Also we need to make it very clear that, when you're talking to special groups, not just acknowledging the need to get vaccinated, but also acknowledging the other issues that these community groups are facing, as people's experiences vary. And I think that was the main points, but anyone from the group, feel free to jump in.
Thank you, Laura and Claire. That was terrific. So we really only have just a couple minutes. Was there another sort of really important point that you feel like you'd like to emphasize, or that perhaps wasn't shared, that you think we should be aware of? Anything that you think, oof, this is definitely, let's do it, USC, come on. I mean, I heard one, there was the comment that one of the biggest motivators for some people in being vaccinated is to hear from their physician that it's a safe thing to do, and that many healthcare providers don't have like a fact sheet or material that it's readily available for them to hand over to their patients, or they don't necessarily, they haven't been sort of primed to do so. And so that seems like something that we could do pretty easily, is to put something in the hands of healthcare providers. We've got, KEC that we could be doing it. We could be looking at something with LAC, USC, our community partners, Watts Health, Altamed. So we could be thinking about something like that. But So that seems something very practical and concrete, and we can do this. Are there other thoughts, like let's do it sort of recommendations?
One thing that stood out to me was just listening to the conversation a lot. It was because as communicators, we think in terms of, like, from Wondros, trying to connect to people emotionally. So it's like we're trying to establish a relationship with people and really validate them. And what stood out for me in our breakout group was also this potential for the power of just acknowledging, and I know there's a lot of research that backs this up too, acknowledging people's fears and concerns. And that when you do that, you kind of open a doorway for people to, like, then have a conversation like, you know, we know you're afraid about side effects, or you're afraid about other issues related to this vaccine, you know, infertility, et cetera. And those are all valid, and not shutting people down about that, and not making them feel like they're stupid for having those fears, or that they're irrational, or, you know what I mean? Like, it's just, there's a lot of power in that. And when you can communicate that I'm with you, and I feel for you, and I know these concerns are really real, and that we're going to address them together, and we can help you. And so that was one of the things that was really powerful to me.
Michelle, you're on mute.
And Lourdes, I want to thank you for constantly reminding me. I didn't want to shut down the conversation but we
thought you were just working on a very uncomfortable silence.
No, well, I was. I did let it go for a little bit, and I was sort of chuckling to myself about that uncomfortable silence. But I will break that silence, and you know, just thank you all for attending. For many of you for presenting, for offering your thoughts and suggestions, for your contributions to this meeting, and also the work that you're doing. Outside of this meeting, I know each and every one of you, every day, are doing such important work. Every one of you are saving lives every day, and I just want to acknowledge and thank you for that work. So I guess as we think about next steps, we will go ahead and take this information and synthesize it. We will go ahead and come up with a summary report, which we will share with you. And again, we want to be able to share that with a range of different stakeholders, because I think so many important conversations and recommendations and thoughts were generated through this discussion. And we do really want to share that with those that can benefit from that. I think, you know, the other thing we can do is just keep you up to date as the work progresses, and maybe even bring you in at different points in time. I know that Wondros, I will share that in addition to the incredible work that Kayla and Lourdes have been doing with the Stay Connected initiative in East LA, they've been running focus groups and town halls and learning so much from the Latino community in East LA. We're doing something very comparable right now in South LA in both the Latino and African American community, a listening tour and really listening to a range of different stakeholders and hearing from their perspective, what are the challenges, what are those messages, who are the messengers, and what are the strategies for delivering educational as well as, you know, again, sort of navigation assistance. So I think we'll probably be having another symposium, which will engage community partners in this same dialogue. And I think it'd be great if we have some of you attend as well. Because, you know, this is so much of what we are also trying to accomplish are these academic community partnerships. And so would really welcome your participation in some of those discussions as well. And then I think we'll just make sure that we continually keep you up to date with what we're doing and what we're learning, what we're finding, what we're doing. We welcome your input at any point in time along this journey. If you are, I was going to say, if you're driving home, Many of you are not driving home. If you are tonight, you know, you have a little quiet moment, or over the weekend, you suddenly think, gosh, there's another idea I just thought of. Please feel free to send us an email, and you know, send me, send Lourdes, and any one of us an email, and share your thoughts. I mean, that this isn't a sort of one and done. This is an iterative process, and certainly a journey. But we want to keep you engaged throughout. And again, thank you for your thoughts and your contributions today. Lourdes, do you have other?
Sure. I just wanted to say that I feel we're finally stepping out of the dark ages of this pandemic. And it's going to take, you know, just brilliant minds like the ones on this symposium today to really lead us out of that. I feel like, you know, like COVID fog, I feel like many of us have been in this sort of fog. And I'm just looking forward to a moment when our messaging can really get to people, and that we can create the change that we really need to see in our communities. I mean, overall, this pandemic has really brought to bear, actually in the most raw way, some of the most serious inequities in our communities. And so COVID may be over in a year or two, but I think that there have been many lessons that we have learned that we will carry through, you know, as we all deal with the biggest, greatest challenge to public health in the history of our own lives, you know, which is just extraordinary. So I look forward to working with each and every one of you, and continuing to work with those that we're working with, because it's going to take us all together to really get there. My mother had 5 brothers and sisters. She always used to say that, you know, with one finger, you can't do very much, but you can lift a whole lot with, you know, with your whole hand. And I think that's what we've got here. And so each one of you in your own areas are major contributions to eradicating this pandemic.
Yep, thank you. And Claire, thank you for bringing up this slide. Here is some our email address, our phone number. So again, please feel free to share any additional thoughts, suggestions, recommendations you have at any point in time. All right, then. Well, you're going to get 1 minute back today. So have a wonderful afternoon and a wonderful weekend. And thank you again for everything you do. And we will talk to you soon.
Thank you. Bye.
Thanks, Michelle.
Thank you.
Thank you, everyone.